ici, et, le son ici.
One, two, yeah, check. One, two, one, two. Et, ici, et.
Strong strategies are the backbone of a health reform financing model, and accurate data are its lifeblood. Across Africa, health systems face structural challenges: fragile fiscal space, over-reliance on donor funding, and weak, fragmented data systems. To build resilient systems, Africa must not only mobilize more resources, it must now mobilize them differently. This translates to innovative instruments, debt for health systems, and blended finance, while also integrating real-time, interoperable data systems that ensure transparency and accountability. The United Nations Economic Commission for Africa, the ECA, is working with member states to rethink financing models and work with new, innovative financing health mechanisms. Central to this approach is embedding health governance tools that strengthen transparency and investor confidence.
One of the issues that we are seeing data, there is a big issue when it comes to collecting data, bringing transparency. And you cannot have investors, you cannot attract investors in the sector if you don't have clear data, if you don't have tools, if you don't have digital tools that can help you really clarify and bring more accountability and more transparency in this. We build the capacities because it's crucial. If the staff working in the ministries of finance, they don't understand that health is an investment, they will be continue looking at it as a social expenditure.
What is not measured is not accounted for. And once we want to account for our health status, we want to account for our productivity, once we want to see Africa transform, then data is the bottom line. And that is why in the area of health investment, especially at the time that we want to distinguish between health from an expenditure point of view and health into an investment discussion, the bottom line should be data. So a number of national statistical offices on the continent produce routine data on economic statistics. So we regularly hear GDP of countries, inflation of countries. But as a continent, we are lacking when it comes to social indicators, in this case, health broadly. From our point of view at the African Center for Statistics, what we see as a challenge is the fragmented way of looking at the health indicators. There isn't much value in looking at health investment independent of the current status of health outcomes, independent of the current status of health outputs. There are some health financing options that are foundational, that would continue to be a public good, a government expenditure, and there are some investment that requires that different financing options would have to come to the table, especially when we are able to link those health outputs to productivity, which is what this research, this project seeks to achieve. At the end of the day, can we ensure that we have healthy Africans that are nutritious, that are able to increase their productivity so that the transformation that we seek to have as a continent, we're going to receive it.
Innovative financing reform in Africa goes far beyond short-term pilots or isolated experiments. The real shift now lies in institutionalizing sustainable mechanisms within Africa's national public financial management systems. Ensuring revenues are predictable, properly ring-fenced, and aligned with individual African national health policies. Debt for health swaps in Africa are innovative financing mechanisms that can turn fiscal pressure into opportunity, redirecting debt service payments towards strategic health investments in Africa while preserving fiscal sustainability. Yet financing innovation alone will not deliver transformation in the African health landscape. Sustainable reform requires intelligence at its core, with reliable data underpinning accountability to sustain comprehensive health reforms across the continent.
All these areas of swaps that we are talking about, for example, debt for health swap, and also other innovative mechanisms of financing, bringing in the private sector, also looking at what the innovations you can do within the government resources to make sure that at least health is guaranteed for all the citizens, and what can be done in the urban and in the rural areas, what should be the formula in order to take care of that financing in a sustainable way. That's why we are undertaking a very big project to see, as ECA, to see what can be done, what are the possibilities, so that from there we can test it in some countries, and if it works out, then we can roll it over to all the African countries. Because otherwise, you cannot rely on development aid forever to finance your basic necessity, such as health financing.
So when we talk about innovative finance, we are saying instead of using all the resources, a huge part of the resources that we have to service our debt, one of the things we can do is actually to agree with the countries that, or with the partners that we are paying the debt back to say, why don't we have an agreement through what we would call a health for debt swap, whereby we have an agreement on the debt that we are servicing to you, and the savings that we make there, we put that saving into building a resilient health systems within the country or within the continent.
Transforming health financing across the continent will require more than just mobilizing capital. Through interoperable systems, individual African governments can simulate trade-offs, monitor health spending, and ensure that investments reduce health inequity and expand access to more citizens. Moreover, through innovative financing models now piloted by the ECA, African states can diversify revenue streams and reduce dependency. And through collaboration and a narrative change, health will ultimately become recognized not as a cost, but as a sovereign economic investment. Africa's prosperity depends on the health of its people, and transforming health financing creates a strong foundation for the continent's future.
So the primary health care will be modernized, where no one will be left behind. We will not be having women dying because they are giving birth in health centers. We will not be having elders removing themselves from the health system because they cannot afford it. And we will not be having situations where international partners are the one really funding health in African countries. So I think looking at it from now, success will be Africa fully responsible of its health and funding it and financing it, and the population really enjoying the technologies and the advancement that these technologies are bringing to the health sector. And our children happy and living in an area where they know that they will not be exposed to shocks and epidemics because their governments are watching and their governments are acting.
Information with household side information. And a specific intervention in this regard is the use of GPS coordinates, because anytime we do household surveys, we locate a structure within which households live and collect data on them. And also, once we do a facility side data collection, the facilities are located within a specific structure which has GPS coordinates. So now we see a number of countries that are able to map household data to facility level data, and that is where we are able to bridge the data from the supply side and the demand side. What we need to do as a continent going forward is ensure that the governance systems around this, the institutional mapping around this, is well legislated, and we follow through to ensure that institutions within the country are communicating in terms of sharing of data. We tend to see instances where facilities are hesitant in sharing data simply because of issues around anonymization, protection of the privacy of the respondents that you've collected data from. But really, it's a matter of sensitizing people on how to anonymize this data and ensure that data is shared across different agencies.
So now there's this whole question about how to, what sort of mechanisms could be utilized to, say, enable countries to invest better in the health sector. So there are questions of, maybe the potential use of debt swaps, innovative financing mechanisms. The other questions of ensuring that you have private sector engagement that is more helpful as opposed to dominating in a way that is not helpful to poor people. How will data then play an important role in ensuring that there is a sort of smooth or a sort of well-oiled machinery to allow the sector to be better invested in?
From our point of view at the African Center for Statistics, what we see as a challenge is the fragmented way of looking at the health indicators. There isn't much value in looking at health investment independent of the current status of health outcomes, independent of the current status of health outputs. So once we want to invest in health, the first thing we need to do, which ACS we are doing in this project, is to provide a landscape not only on the financing mechanism, but look at issues such as universal health coverage, look at issues such as neonatal mortality rate, look at issues such as maternal mortality rate, and use this as basis to say that, for instance, if the SDG target on neonatal is, let's say, 12 per 1,000 live births, we say that which countries are doing well in neonatal, which countries are doing well in maternal mortality, which countries have better health coverage, and then relate that to different health financing options. There are some health financing options that are foundational, that would continue to be a public good, a government expenditure, and there are some investment that requires that different financing options would have to come to the table, especially when we are able to link those health outputs to productivity, which is what this research, this project seeks to achieve. At the end of the day, can we ensure that we have healthy Africans that are nutritious, that are able to increase their productivity so that the transformation that we seek to have as a continent, we're going to receive it.
In your view, as heading ECA's African Center for Statistics, what does success look like in the area of investing in health? If you were to imagine the continent 5 years from now, maybe 10 years from now, how does success look like? From a data perspective, from an integration of data, for better informed decisions by policymakers, by the public, and so on, the sensitization part, and so on, and that change of.
We look.
Strong strategies are the backbone of a health reform financing model, and accurate data are its lifeblood. Across Africa, health systems face structural challenges: fragile fiscal space, over-reliance on donor funding, and weak, fragmented data systems. To build resilient systems, Africa must not only mobilize more resources, it must now mobilize them differently. This translates to innovative instruments, debt for health systems, and blended finance, while also integrating real-time, interoperable data systems that ensure transparency and accountability. The United Nations Economic Commission for Africa, the ECA, is working with member states to rethink financing models and work with new, innovative financing health mechanisms. Central to this approach is embedding health governance tools that strengthen transparency and investor confidence.
One of the issues that we are seeing is data. There is a big issue when it comes to collecting data, bringing transparency. And you cannot have investors, you cannot attract investors in the sector if you don't have a clear data, if you don't have tools, if you don't have digital tools that can help you really to clarify and bring more accountability and more transparency in this. We build the capacities because it's crucial. If the staff working in the ministries of finance, they don't understand that health is an investment, they will be continue looking at it as a social expenditure.
What is not measured is not accounted for. And once we want to account for our health status, we want to account for our productivity, once we want to see Africa transform, then data is the bottom line. And that is why in the area of health investment, especially at the time that we want to distinguish between health from an expenditure point of view and health into an investment discussion, the bottom line should be data. So a number of national statistical offices on the continent produce routine data on economic statistics. So we regularly hear GDP of countries, inflation of countries. But as a continent, we are lacking when it comes to social indicators, in this case, health broadly. From our point of view at the African Center for Statistics, what we see as a challenge is the fragmented way of looking at the health indicators. There isn't much value in looking at health investment independent of the current status of health outcomes, independent of the current status of health outputs. There are some health financing options that are foundational, that would continue to be a public good, a government expenditure, and there are some investment that requires that different financing options would have to come to the table, especially when we are able to link those health outputs to productivity, which is what this research, this project seeks to achieve. At the end of the day, can we ensure that we have healthy Africans that are nutritious, that are able to increase their productivity so that the transformation that we seek to have as a continent, we're going to receive it.
Innovative financing reform in Africa goes far beyond short-term pilots or isolated experiments. The real shift now lies in institutionalizing sustainable mechanisms within Africa's national public financial management systems. Ensuring revenues are predictable, properly ring-fenced, and aligned with individual African national health policies. Debt for health swaps in Africa are innovative financing mechanisms that can turn fiscal pressure into opportunity. Redirecting debt service payments towards strategic health investments in Africa while preserving fiscal sustainability. Yet financing innovation alone will not deliver transformation in the African health landscape. Sustainable reform requires intelligence at its core, with reliable data underpinning accountability to sustain comprehensive health reforms across the continent.
All these areas of swaps that we are talking about, for example, debt for health swap, and also other innovative mechanisms of financing, bringing in the private sector, also looking at what the innovations you can do within the government resources to make sure that at least health is guaranteed for all the citizens, and what can be done in the urban and in the rural areas, what should be the formula in order to take care of that financing in a sustainable way. That's why we are undertaking a very big project to see, as ECA, to see what can be done, what are the possibilities, so that from there we can test it in some countries, and if it works out, then we can roll it over to all the African countries. Because otherwise, you cannot rely on development aid forever to finance your basic necessity, such as health financing.
So when we talk about innovative finance, we are saying instead of using all the resources, a huge part of the resources that we have to service our debt, one of the things we can do is actually to agree with the countries that, or with the partners that we are paying the debt back to say, why don't we have an agreement through what we would call a health for debt swap, whereby we have an agreement on the debt that we are servicing to you, and the savings that we make there, we put that saving into building a resilient health systems within the country or within the continent.
Transforming health financing across the continent will require more than just mobilizing capital. Through interoperable systems, individual African governments can simulate trade-offs, monitor health spending, and ensure that investments reduce health inequity and expand access to more citizens. Moreover, through innovative financing models now piloted by the ECA, African states can diversify revenue streams and reduce dependency. And through collaboration and a narrative change, health will ultimately become recognized not as a cost, but as a sovereign economic investment. Africa's prosperity depends on the health of its people, and transforming health financing creates a strong foundation for the continent's future.
So the primary health care will be modernized, where no one will be left behind. We will not be having women dying because they are giving birth in health centers. We will not be having elders removing themselves from the health system because they cannot afford it. And we will not be having situations where international partners are the one really funding health in African countries. So I think looking at it from now, success will be Africa fully responsible of its health and funding it and financing it, and the population really enjoying the technologies and the advancement that these technologies are bringing to the health sector. And our children happy and living in an area where they know that they will not be exposed to shocks and epidemics because their governments are watching and their governments are acting.
Ladies and gentlemen, welcome back. May I ask you all kindly to make your way back to your seats, please. We'll be starting very, very shortly. Mesdames et messieurs, c'est un plaisir de vous retrouver. Merci de bien vouloir regagner vos sièges, s'il vous plaît, car nous allons commencer dans quelques instants. Ladies and gentlemen, welcome back. Rebonjour à tous, c'est un vrai plaisir de vous retrouver. J'espère que la pause aura été rafraîchissante, que vous en avez profité également pour faire du networking, car on est aussi ici pour ça. Ladies and gentlemen, welcome back. I hope that you enjoyed the coffee break and that it was also a networking break. I'm just going to give you just a few seconds, please, to take your seats. We'll be continuing very, very shortly. Je vous laisse juste quelques secondes, s'il vous plaît, pour vous installer, car nous allons commencer très, très rapidement pour ne pas prendre encore plus de retard. So, ladies and gentlemen, we have set the vision, but now let's make it official. And so to formally launch the Invest in Health Africa initiative, and also open the financing commitment register, which is the living document that will track every commitment made in this room today, please join me in welcoming the Chief of Staff of the United Nations Economic Commission for Africa, Mr. Aboubakry Diaw.
Good morning. So thank you. We have listened to several speeches this morning talking about the real challenge, how African countries can really find a way to finance in a sustainable way their health issues. So, and then we also have, I think we listened also to some of the solutions that has been proposed by the different speakers. What we are trying to do at ECA is to look at both the challenges that we know, but also at the solutions that we are proposing. So looking at the whole issue of health financing, and we have heard some speakers mentioning that Africa is spending more than 140 billion on health, but only 41% of this amount is funded directly by governments. So how can we help governments to address this issue? Because the 60% that are not funded by the government are funded by households or international partners. This is why we said, how can we bring ECA's expertise that really on the macroeconomic policy to help countries ensure that fiscal strategies and health policies are really embedded in macroeconomic policy. How do we increase, because we have also noted from the different speakers that there is a lack of trust and accountability in the processes, because 40% of this amount that is funded is not really going to health, or is not spent in an effective and efficient way. This is where we are really adding a data and digital component to the initiatives, where data will help us to have a clarity on a better tracking of the resources, a better allocation of the resources, looking at the impact, looking at how this investment can drive the change that we are expecting, but also building on technology, because we cannot talk today about development without technology. So how do we use the frontier technologies in line to what we are with what we are saying in this Economic Commission of Africa report, and also the topic of the COM this year? How do we bring in technology to ensure that it will be a driver or a leapfrog for Africa's development when it comes to health? Capacities is an issue, and the initiative is also looking at how do we bridge this capacity gap? How do we partner with institutions, especially African institutions, universities, to bring the capacity we need into the ministries of finance that can help them have a better understanding of the challenges from the health perspective, but also ensure that the tools that we are proposing are used in an effective and efficient way to help ministers track the budgets, but also allocations and impact. And one important thing that has been also mentioned by most of the speakers is how do we use what we have already, AFCFTA and all the protocols linked to AFCFTA. Because when we talk about pooled procurement, when we talk about value chains and the challenges associated to them. When we talk about portability of the health insurance, these are opportunities that we can really plug into the FCFTA protocols and see how we can scale them up. And one important thing that has been also mentioned by most of the speakers is how do we change the narrative around health. Health is not a social expenditure. It's an economic investment, and we need to really ensure that our governments, our ministers of finance, and our partners, when they speak about health, they really look at it from the investment perspective, because at the end, this is what matters, and this is the reality. Just to give you I was talking to some of our partners yesterday in the preparation of this, and one minister of finance was telling me, I don't feel comfortable in having this discussion because the Minister of Health is not here. And I told him this is exactly why we want to have this meeting, because we want this discussion to move from ministries of health to ministries of finance, because the real issue is financing. So just to give you an example on one of the tools that we are trying to implement, data platform that can, on the data side, show us what are the real tools that we can put in place that can help us have a better understanding of the budget allocations, have a better understanding, have a better visibility on the tracking when it comes to financing. So I will be happy to introduce my colleague Sam, who is the director of the Africa Center for Statistics, and his team developed a data platform tool that can be really used by all of us, ministers of finance especially, and this tool will help us to really deep dive into some of the things that we have mentioned in terms of tracking resources, looking at the different gaps, and finding really ways to make it more accessible and more effective for the Minister of Finance to look at this. So Sam, please join me and introduce the platform that your team developed to help us address the gaps when it comes to health financing. Over to you.
Thank you very much, Abu. Excellencies, honorable ministers, distinguished delegates, esteemed ladies and gentlemen, good afternoon. So as Abu indicated, at the Africa Center for Statistics, we are supporting this initiative of transforming health financing on the continent from a data perspective. Before I launch into the portal, permit me to make some quick remarks so that we have the portal in a specific context. So the portal has the name Africa's Health Financing Gaps and Investment Portal. And we are emphasizing the gaps and investment to give the portal a unique proposition away from other existing health investment financing portals, such as what we have with the WHO. Certainly in line with the UN Data Common Principles, we are putting up this portal, ensuring that there is interoperability, there is integration across these portals. Three quick things that I want to highlight. I'm emphasizing a portal away from a dashboard because our focus is not just to have a repository of statistics with its visualizations. As has been indicated throughout the morning, we go beyond a repository of statistics and visualizations to ensure that it is a portal that allows for information exchange, specifically information around investment decision makings and how we can bring all these together to ensure regional value chains. So emphasis is on the fact that it is a portal that has different domains that allows, more importantly, for information sharing beyond a visualization of statistics. The second context that I want to put to the table before we get into the demo is the fact that we've built this portal around three domains. As we're going to see, and you see on the screen now, we have a static situational analysis of where we are that gives us baseline information so that as we try to distinguish between health as
an investment and not as an expenditure, health from an economic return point of view and not from a social point of view, we know where this is taking us to. So the first platform that we have is a situational analysis of where we are. Secondly, we try to humanize the portal by having an interactive storytelling platform. So you see on the bottom right of the portal that there is a chat function that allows policymakers not to burden themselves in navigating their way through the portal, but thinking about how to ask certain basic questions, as in which country is investing in the pharmaceutical industry, and that information will be provided. And the third domain that we provide, which is the core of this exercise, is going forward. Once we have the foundational data, how do we get member states? And as we build the commitment of registers, we are hoping that we're not going to commit only financially, but we're going to commit to information sharing so that we can see how, as I indicated, regional value chains can be enhanced. The third context that I put to it is we have built this portal from a theory of change framework. So it is not just a portal that gives you where is the financing gap on the continent, but we look at the entire theory of change in terms of what are the health inputs, what are the health financing mechanisms, and more importantly, the responsiveness of health financing to health outcomes. It is only at this stage that we can begin to think about the macro imperatives of health financing. Because if really health would have to make a difference, then it has to translate into productivity, and then it has to translate into our GDP. So on this portal, as we can see, we have 9 tabs ranging from overview through spending, financing gaps, which, as I indicated, is the value addition for this portal, through to what we see at the country level. On the overview tab, as I indicated, it gives us the situation. So we see the number of countries that are spending above the health per capita expenditure of 112 for low income countries, countries that are spending more than $146 for lower middle income countries, and countries that are spending more than $477 for the upper middle and high income countries. So on that front, as a continent, we see only 3 countries as our 2023 data that are meeting that target. What is of importance to us is, as I said, this is a theory of change framework. So on the second row, the last 3 grades that you see are giving us the health status and the health outcomes, so that you don't just look at the health financing argument, but ask yourself whether the health financing and the health status and outcomes are moving in the same direction. So specifically, we pick 3 SDG indicators related to health. That is the universal health coverage, where we see just about 50% on the average for the continent. Only 9 countries are meeting the neonatal 12 deaths per every 1,000 live births, and only 8 countries as of 2023 are meeting the maternal mortality SDG target of 70 deaths for every 100,000 live births. We get onto the financing gap tab, and on the financing gaps tab, as I indicated, our goal is not just to think about where we are, but what it will take us to where we ought to be. So what we see on this portal is not just the distance away from what the threshold or the indicative target is, but the differences for the entire continent and the differences across different income groups. We've seen a number and some numbers coming up this morning in terms of what the gaps are. But what we see on this portal is, irrespective of the different income groups across all the member states, we have a gap of $125.4. And obviously this varies across the different income groups, ranging from 103 to 233.50. We don't restrict ourselves to only one financing situation, but this portal gives us the different financing options, so that we would have the opportunity to look at the health financing gap from an adequacy point of view, from a priority point of view, from an allocation point of view, and more importantly, from a financial protection point of view. So all four measures or perspective of health financing has been addressed on this portal. Then we move on to the outcome tab. On the outcome tab, it goes back to how I started the conversation. It is not just about what the gaps are. We ask ourselves whether the gaps are translating into what we expect in terms of whether we are meeting the SDG targets or not. So what you see in the first instance is South Africa, as at 2023, is the only country meeting the Abuja Declaration of 15% of its health budget. And we ask ourselves whether, from the South Africa point of view, it is having a universal health coverage of more than 75%, it is meeting the neonatal target of 12 deaths per every 1,000 live births, and whether it is meeting the maternal mortality target of 70 deaths per every 100,000 live births or otherwise. So with the exception of the neonatal target, South Africa falls short of the universal health coverage with a threshold of 75% and the maternal mortality of 70 deaths per every 100,000 live births. So we do the same for the other financing indicators, look at the countries that are meeting those thresholds and ask ourselves whether it's translating into that. Why we do that is the strategic need to do smart investment. So it is not just about the gaps, it is whether the gaps are translating into what we expect or otherwise. We go back to the investment tab, as I indicated. This portal is meant to ensure that all member states on the continent are communicating from their health investment point of view. So going forward, we're going to count on member states to furnish us with information on health interventions, in what areas, at what amount, which partners they have. And then later in the day, my other colleague will show us how a simulator portal would help analyze these different investment opportunities to ensure that our investment translates into productivity and has a macroeconomic imperative. Thank you very much.
Thank you very much, gentlemen. What a useful tool to have to know exactly where we stand, and a brilliant, very practical demonstration as well. So, ladies and gentlemen, now we dive into our next session, from fiscal strategy to innovative financing, and we'll move from fiscal foundations to capital mobilization in 3 sequential parts. Our core argument today is simple but critical. Innovative financing instruments are only viable when they are grounded in credible, fiscally embedded national strategies. And so to anchor us, if I may say, into fiscal realism, please join me in welcoming the Deputy Director of the Fiscal Affairs Department at the IMF, Mr. Ali Abbas.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Bonjour. Good afternoon. It's a pleasure to be here. And let me start with a few slides on the work that the IMF has done on establishing the macro criticality of health spending, public health spending especially. So as you can see, the left chart shows work that we've released recently in October of the long-term output gain from a 1 percentage point of GDP spending reallocation toward human and physical capital investment in emerging and developing economies. The blue bars are for infrastructure investment, and the yellow bars are for human capital investment. And as you can see, the deviation or the increase in terms of output is very substantial over the long term. So you can get a 1 percentage point of GDP increase leading to almost a 6 percentage point of GDP increase by 2050, so in 25 years. On the right chart, this is ongoing research on internal rates of return for health, infrastructure, and education spending, all public, in sub-Saharan Africa. And there you can see that the returns for health spending exceed those on infrastructure and education. So this is work that we've recently done to establish the returns from public health spending. The second set of charts is just documenting what has been said earlier about how is health expenditure financed. And you have charts here for advanced economies, emerging markets, low-income countries, and sub-Saharan Africa. And you can see the difference in financing levels and composition. So if you focus on sub-Saharan Africa, the total spend is 4.1% of GDP. Only 1.2 percentage points of that is public health spending. 1.8 is private, which is households paying from their own pockets. And then 1.1 is foreign financed. And the right chart shows the share of health spending in total public spending in sub-Saharan Africa. And you can see that the level, the cross in the middle is the average, and the line is the median. The median is pretty close to low-income and developing countries, but it's much below, well below emerging markets and advanced economies. So clearly, given the benefits from health spending, the level of spend in low-income countries in sub-Saharan Africa seems low. So for these reasons, health expenditure is seen as a macro-critical issue by the IMF, and our engagement, because we are not a specialist institution in health, on health issues, we defer to organizations like the World Health Organization, the UN, and the World Bank. Our engagement on social spending more broadly, which encompasses health, education, and social protection, is guided by the macro criticality criterion. And we focus on three aspects here: adequacy, efficiency, and fiscal sustainability. The adequacy question that we ask is health spending sufficient to achieve policy goals? Spending efficiency, are outcomes achieved at reasonable cost? And a lot has been said on this already. And the third is fiscal sustainability, are health spending and financing sustainable over time? When we look at these three aspects, on the first one, the key messages from this chart is that spending in many sub-Saharan African countries is too low to allow for gains in access and coverage. This chart shows on the horizontal axis public health spending levels, and on the vertical axis universal healthcare index. And you can see that much of Africa is bunched towards the bottom left, and the median levels both for public health spending and for the UHC index are well below the medians for emerging markets and developing economies, and of course well below those for advanced economies. On efficiency, there's a major scope in sub-Saharan Africa to move closer to the frontier for emerging and developing economies by improving efficiency at existing spending levels. So if you can see this, the frontier here represents what has been achieved in terms of healthy life expectancy for any given level of public health spending. And there are many countries here in sub-Saharan Africa which are well below that frontier for emerging and developing economies. And then finally, sustainability, which is a question that is on the minds of many, including in the context of the evolving energy and food price shock and the impacts that it will have. On the left chart, you see public spending pressures that we have estimated over the next 10 years, minus the 2024 level of that spending. This is in percent of GDP. So you can see that for low-income and developing countries, it's a very sizable increase, an annual increase in the level of spending across different categories. 2.8% of GDP is health and education, but then there is also infrastructure, there is defense, there's climate, and then there is aging, which is pensions. And on the right chart, this is something that was mentioned, that many countries now spend more on interest payments on debt than they do on public health spending. And you can see many of the countries here are above the 45-degree line in this chart, which has interest payments versus public health spending. And clearly the median level for public health spending, which is around 1.2 percentage points, is almost half of what the median is for interest payments. So this shows the extent of the challenge, that there are competing spending pressures, rising interest bills, and of course, declining concessional financing. Let me spend just a few minutes on how we think public health spending can be raised without jeopardizing debt sustainability. Of course, the point about efficiency in public spending is well taken. So to the extent that more can be extracted from the same level of spending, that should be done. But if spending levels have to rise, how do you do that without jeopardizing debt sustainability? So the first point here is better use of financing options and improvements in debt sustainability frameworks can help. The key issue here is that adequate and efficient health expenditure can support long-run growth and resilience. But because this spending is upfront, and the growth and revenue benefits come later, they are backloaded, debt can initially rise. And so the debt sustainability picture can, if looked at in a sort of a myopic way, look worse. So how can we get around this? How can we address this? The first is higher concessional financing or low-cost financing resolves this tension because it aligns the profile of debt service payments with backloaded returns from health spending. Now, because such financing is on the decline, it's important to target whatever is received better towards health priorities. The second point is debt swaps and the use of these. They can help if they are transparent, aligned with national priorities, designed to avoid diverting resources from other urgent development needs, and they should not be intended to replace needed debt restructurings. They are most effective when supported by multilateral or bilateral credit enhancements under the IMF World Bank three-pillar approach to assist countries facing liquidity problems. And then finally, there is an ongoing review of the IMF's debt sustainability framework for low-income countries, which will include a long-term module to assess the growth and debt effects of investment in human capital infrastructure and climate adaptation. And there are tools there which may help bring out better these long-run benefits and how they impact debt sustainability. The second point that I would like to make here is that mobilizing domestic revenues remains critical and can provide a robust source of financing for public health spending, especially in a context where foreign financing is declining. On the left, you have charts where we have documented tax potential and tax gap estimates across several country groups. For African emerging markets, there's this tax potential of 7.4 percentage points of GDP. And for African low-income and developing countries, it's 4.1 percentage points of GDP. The right charts show where does this tax potential come from. Part of it comes from the policy gap and reducing that policy gap. You have estimates of tax expenditures here as percent of total tax revenue, which are quite sizable. And then on the bottom, you have the administration gap, VAT compliance gap. So if you look at for low income and developing countries, almost 40% of the de jure VAT receipts are not collected due to weak compliance. The third point I'd like to make is that despite some benefits, golden rules, golden fiscal rules are not a good way to protect health spending. Golden rules exclude capital expenditures partly or fully from the fiscal rule deficit or expenditure ceilings. That's their definition. And by doing this, they seem to create room to borrow so governments can finance physical and human capital expenditure free from the budget constraints. However, these rules run into problems in practice. There are incentives to misclassify any and all spending as investment so that it can be excluded. The low transparency and weaker comparability of fiscal data, weaker link between fiscal targets and debt dynamics because you're excluding a large part of spending, and more rigidity over time as the exemptions from the fiscal, the deficit definition for the fiscal rule accumulate. A better way is to nest health spending within credible medium-term fiscal frameworks. And here, the close coordination that was mentioned between health and fiscal policy can improve adequacy, efficiency, and sustainability. By anchoring health priorities in realistic medium-term frameworks, which are aligned with fiscal space, identifying the potential for efficiency gains through spending reviews, program evaluation, and unit cost benchmarking, allocating resources to highest impact services using costing and strategic analysis, integrating health financing into core budget PFM systems to strengthen predictability and accountability, and supporting reforms with targeted CD and clear institutional roles. Finally, just a couple of slides on IMF engagement on health spending issues. We had a key strategy paper come out in 2023. The link is there on IMF engagement on health spending issues in surveillance and program work. And we've done analytical work in several surveillance cases. 3 are showcased here in Angola, in Tanzania, and Benin. We also, in our program, set conditionality on health spending in fund programs. You can see that in Ghana, Gabon, Madagascar, Tunisia, Tanzania, we've had a set of conditions. The Madagascar one, integrate health and education sectoral spending plans into a medium-term budget framework, was set as a structural benchmark in our program. And similarly in Tanzania, the hiring of 10,000 additional health workers to address gaps. There are also quantitative conditions that can be set, like in these countries, social spending floors, minimum expenditure on health, education, and social safety nets in the program envelope. And then finally, collaboration for us is key, including on CD with development partners. The fund's approach is more top-down, aggregate, to provide the aggregate macro-fiscal context for health spending, whereas other development partners provide more bottom-up sectoral and individual program design issues. We leverage frameworks and evidence from the World Health Organization, World Bank, UNICEF. Participation of external experts is common in our capacity development support. And of course, when we set conditions in our programs, we also rely on specialized agencies to monitor and report on those. Thank you very much.
Thank you, Deputy Director, for grounding us so firmly in fiscal reality. This is exactly the foundation that we need. So let's now move from general fiscal endorsement to country-specific reform pathways. And to set the scene, let's welcome now Mrs. Mada Halmi, Population and Development Expert at UNFPA. Welcome.
Bonjour. Juste le temps pour que la présentation soit partagée. Ravi, honoré d'être avec vous en cette honorable assemblée. Les slides seront en anglais, mais la présentation en français, donc une balance équitable. Alors, ce que nous souhaitons partager avec vous aujourd'hui en tant qu'une FPA, c'est la dynamique démographique qui est en lien avec l'espace fiscal et comment ça impacte le financement de la santé. En général, lorsqu'on pense à la démographie, on pense à des statistiques qui pourront être utiles pour le ministère de la Santé pour, par exemple, décider où on va construire le prochain hôpital. Mais ça va au-delà de ça. Vous allez voir que les données démographiques et l'analyse démographique représentent le moteur macro-fiscal qui va expliquer, qui va impacter les 30 prochaines années au sein de l'Afrique. Mais avant ça, essayons de voir le prochain slide. Voilà. Essayons de voir d'abord comment la démographie est en train d'évoluer au sein de notre continent. D'ici 2063, on voit que l'Afrique va atteindre 3 milliards d'individus. Et nous voyons en couleur verte le pourcentage de la population en âge d'activité qui va atteindre 65,5. Et c'est le moment où on parle de l'ouverture d'une fenêtre démographique très, très importante et sans précédent pour le continent. Mais cette réalité, il diffère lorsqu'on essaie de voir les 4 parties de l'Afrique. Et vous voyez entre la comparaison entre la couleur jaune en haut et en bas, entre l'Afrique de l'Est et l'Afrique de l'Ouest en haut, et l'Afrique du Nord et l'Afrique australe en bas, on voit l'ampleur de vieillissement pour le niveau bas et l'ampleur de la continuité de la natalité, de la fécondité pour l'Afrique de l'Est et l'Afrique de l'Ouest. Et nous voyons que ça, on peut clairement dire que les rôles des ministères de la Santé et de la Finance seront différents entre le haut et le bas. C'est vraiment deux façons de voir et c'est des politiques économiques, sanitaires qui seront complètement différentes. Ici, on va introduire avec vous la notion de la fenêtre démographique. La réalité africaine n'est pas la même. Au sein de ce continent, nous avons des populations qui sont âgées de moins de 15 ans et les populations qui sont âgées de plus de 65 ans. En l'occurrence, on parle de la population dépendante et qui est prise en charge par la population en âge d'activité et donc la population qui est entre 15 et 65 ans. Selon les systèmes des Nations Unies, lorsque nous avons une population de moins de 15 ans qui est moins de 30% et que le vieillissement est encore moins de 15%, là on parle d'une fenêtre démographique. On parle d'un ratio de dépendance dans lequel 1,7 d'actifs prennent en charge une personne. À ce moment-là, on est dans une fenêtre démographique. Mais lorsqu'on essaye d'examiner le continent africain à partir de ce ratio démographique, vous allez remarquer qu'on va pouvoir remarquer qu'il y a 3 groupes dans le continent africain. Il y a 11 pays qui sont déjà dans une situation où la fenêtre démographique est déjà ouverte et elle est en train de se fermer. Et ça rejoint le slide avant, lorsqu'on a parlé de l'Afrique du Nord et l'Afrique australe. On va retrouver des pays comme la Tunisie, le Maroc, l'Algérie, l'Afrique du Sud, le Seychelles. Et là où la politique économique et la politique sanitaire seraient complètement différentes du deuxième groupe. Le premier groupe sera beaucoup plus dans une logique d'éviter le piège de vieillissement avant de traiter la réforme de la retraite et l'ampleur des maladies non transmissibles comme le cancer ou bien les maladies cardiovasculaires ou le diabète. Par contre, dans le groupe 2, dans lequel on a pris juste des exemples comme le Kenya, la Tanzanie et le Sénégal, là, on approche de l'ouverture de cette fenêtre démographique. On n'est pas encore dans ce ratio de 1,7 actifs qui prennent en charge une personne dépendante. Et là, la politique et la décision va être différente. Les engagements politiques seraient beaucoup plus autour du renforcement du capital humain, la formalisation du travail et la mise en place des bases d'un système de protection sociale solide. Le troisième groupe dans le continent, c'est des pays qui sont encore loin de cette fenêtre démographique, comme le Tchad ou la RDC ou la Somalie, pour lesquels on voit une ouverture de la fenêtre démographique en 2050, voire même en 2060 pour un pays comme le Nigeria. Et là, on peut se dire peut-être c'est pas la même urgence, bien au contraire. C'est là où on doit travailler pour favoriser cette ouverture de fenêtre démographique, et c'est là où on doit travailler sur la réduction de la mortalité infantile, dans la planification familiale, dans l'éducation de la fille et dans la santé sexuelle et reproductive. En voyant ces trois groupes démographiques, ce n'est ni mauvais ni une bonne nouvelle d'être dans un groupe ou de l'autre. C'est juste une répartition selon la situation des pays par rapport à leur fenêtre démographique. Ça va dépendre des politiques et des engagements qu'on va mettre en place pour rendre cette situation démographique positive ou négative par rapport à la captation de ce qu'on appelle le dividende démographique. Et pour partager avec vous l'expérience des pays de l'Asie qui nous ont précédés un peu, qui étaient dans une situation un peu similaire du groupe 1 ou une partie du groupe 2. Dans les années 80, ces pays asiatiques, ils ont saisi cette fenêtre démographique et ils ont réussi dans certains pays comme la Corée du Sud à multiplier leur croissance économique avec 85 fois. Imaginez ça. Il y a des pays qui ont multiplié leur croissance économique en 30 fois, en 10 fois dans les pays de l'Asie comme le Taïwan, le Singapour ou Thaïlande. Ça veut dire qu'ils ont choisi les meilleures politiques et les meilleurs engagements au moment où cette fenêtre démographique a été ouverte. Et donc, l'équation, elle est claire. Si on a une démographie, une fenêtre démographique et on continue à avoir des politiques sociales, sectorielles isolées, malheureusement, on sera dans le piège dont on a parlé tout à l'heure, le piège de vieillissement avant que le pays soit enrichi. Et on sera dans une gestion de la retraite, mais vraiment très, très tardive. Mais si nous avons une fenêtre démographique et on met en place une architecture budgétaire et sanitaire intégrée, alors là, nous avons plus de chances d'obtenir un dividende économique et un dividende économique qui soit durable. Et je finirai avec cette slide dans laquelle on aimerait partager un pacte macro-sanitaire entre deux ministères qui sont clés dans cette logique démographique, le ministère de la Santé et le ministère des Finances. Par rapport au ministère des Finances, le message sera clair, il va falloir créer d'une façon durable un travail formel, parce que dans le secteur informel, on a l'illusion que la population elle est en train de travailler. Mais une fois arrivé à la vieillesse, il va se retrouver sans pension de retraite, sans couverture médicale, et du coup, il alourdit la population qui doit être prise en charge. Et ce ratio dont on a parlé tout à l'heure, le ratio de dépendance démographique, ne serait plus soutenable. C'est pourquoi nous avons besoin d'une formalisation dans laquelle les travailleurs, ils cotisent et ils préparent la gestion de la retraite, de la protection sociale et du vieillissement. Nous avons aussi besoin d'un financement qui doit être rééquilibré parce que jusqu'à maintenant, en Afrique, on peut voir que la majorité des financements sanitaires, il va dans les budgets de santé pour les maladies d'infection. Alors qu'aujourd'hui, l'évolution des maladies non transmissibles, cardiovasculaires, diabète, etc., sont de plus en plus répandues et ça, c'est des maladies qui consomment beaucoup de budget et qui sont de longue durée. En face, nous avons besoin aussi d'un engagement de la part du ministère de la Santé pour une approche de cycle de vie dans le suivi et dans la santé des femmes et dans la santé sexuelle et reproductive. Nous avons aussi besoin que le ministère de la Santé puisse, en interne, pouvoir transverser et switcher vers une politique sanitaire qui donne plus de place aux maladies non transmissibles. Et dernièrement, nous avons entendu ce matin beaucoup parler que l'investissement, que la santé, les dépenses en santé, c'est pas, ou bien le financement de la santé, c'est pas des dépenses, c'est de l'investissement. Mais face aux financiers, face aux institutions financières, nous avons besoin de dépasser le discours moral pour aller vers des arguments de retour d'investissement. Nous avons besoin de donner des arguments pour être capables, en tant que département de santé, de convaincre avec des études, des analyses de retour d'investissement, pourquoi je dois continuer à investir dans la santé. Donc, pour clore mon intervention, lorsqu'on parle de dynamique démographique, la démographie, c'est la situation, c'est le destin, c'est l'architecture de pays. Il n'est ni positif ni négatif. Il va falloir choisir les politiques et les engagements adaptés pour pouvoir tirer profit de cette fenêtre démographique qui va se présenter pour chacun de nos pays en Afrique. Et merci.
Merci beaucoup, Monsieur Mehdi Halmi, pour cette excellente présentation. Il est vrai qu'en fait, l'Afrique, c'est le continent de la jeunesse, mais faisons vraiment en sorte qu'il soit également le continent de la santé. Well, let me switch back to English. To now move from general fiscal endorsement to country-specific reform pathways. And now to set the scene, let's welcome... Sorry, on a déjà fait. We're now moving straight, in fact, to the fiscal foundations of sustainable health financing. So this is where we meet policies and the budget line. And to lead this critical segment, please join me in welcoming our moderator, the Minister of Health for Seychelles, His Excellency Dr. Marvin Fani. And joining him on stage to tackle these very important issues, please also welcome His Excellency Tahir Hamid Ngilin, Minister of Finance, Budget and Economy of Chad. Let's all welcome, please, Her Excellency Mrs. Maria Ebiaka Moete, who's Secretary of State for Finance, Planning and Economic Development of Equatorial Guinea. Ladies and gentlemen, please, if you would like to come and join us on the stage. A round of applause as well for all our guests. I think that we are all expecting lunch very soon. But let's try to stay motivated and dynamic for this next segment. So let me call again, our excellencies will be joining us for this conversation. His Excellency Tahir Hamid Ngilin, Minister of Finance, Budget and Economy of Chad. Please, if you could join us. Also from the Equatorial Guinea, Her Excellency Maria Ebiaka Moete, Secretary of State for Finance, Planning and Economic Development. Are we in the room? Let me then proceed to His Excellency Sheku Hamed Bangura, Minister of Finance of Sierra Leone? No? How about Honorable Bouha Saidi, Governor of the Central Bank of the Gambia? Well, Excellency, it might just be you and me. Yes. Let me try our minister from Sudan, His Excellency Jibril Ibrahim. Yes. So it's going to be a tête-à-tête, like we say in France. Shall I leave you two together and try to locate the rest of our team? Thank you. Ladies and gentlemen, thank you very much for your patience. We are just trying to locate all our panelists. In the meantime, it's going to be up to you two, gentlemen. And if anybody comes, we'll make sure to introduce them as well. Thank you. All right, so joining us as well on the stage, we have His Excellency Marc Abégué, Minister Delegate for Economy, Finance, Debt and Shareholdings in charge of the budget of Gabon. All right. So let me call His Excellency Sheikh Ahmed Bangu, Honorable Bouai Sahidi, Governor from the Central Bank of the Gambia. Please, if the Governor of the Central Bank of the Gambia could also join us on the stage. Well, I think that this session is actually quite fun, to be honest, because we'll remember it. So that's quite memorable. All right. I think, Excellencies, that you can just proceed, and whoever, I'll make sure to discreetly come behind you and let you know. Thank you very much for your patience. Thank you very much for your patience. And I think that they deserve a big round of applause just to kind of, because this is not easy at all. Thank you all.
Thank you. Excellencies, colleagues, good afternoon. Thank you for joining this critical discussion. We meet at a time when Africa's health financing model is under significant strain. Governments finance less than 41% of health expenditure, while out-of-pocket payments continue to push millions into poverty each year. The central premise of this session is simple but important. In health, if health is not embedded in macro fiscal frameworks, then no financing instrument, no matter how innovative, will be sustainable. Allow me to briefly ground this in a small island context. I myself am a pediatric surgeon by profession before becoming a minister, so I know what it is to deliver health at a clinical level, and also now as a minister, what it takes to actually get it done. In Seychelles, we allocate approximately 12% of our national budget to health, translating to around 4% of our GDP, while maintaining a free health system at the point of delivery. This demonstrates that even within constrained fiscal space, prioritization is a policy choice, not just an economic outcome. Today, our objective is not to restate challenges, but to focus on practical country-level solutions. What has worked, what has failed, what is realistically implementable. So I encourage my two colleagues to be frank, practical, and forward-looking. So let me start, first of all, by asking my colleague, Excellency Ibrahim. I will address the first question to you. My question Your Excellency, is how have you translated health priorities into fiscal language that resonates with your ministerial finance?
Thank you very much, Minister, and very good evening to everyone. Being a person interested in human capital building since the time of my higher education, I don't consider expenditure on health as expenditure. From the very beginning, I believe it's an investment, and an investment that saves a lot of money at the end. And actually, if the purpose of development is human, and the tool for development itself is also human, you have to pay for human to become a tool and beneficial of development. So health is an investment. Any expenditure on health and education, an investment in human capital. That's how I look at it. That's why the Minister of Health and the Minister of Education are the best friends of the Minister of Finance in Sudan. When I came to this ministry and took the portfolio, I thought I have to push for health to reach the Abuja level. And actually, we were very close to that. In 2023, our budget, we planned to pay 14.7% on health. Unfortunately, in April, the war erupted, and we couldn't do as we wished. But still, when we prioritized our expenditure as a result of the war, again, health came at the top of what we do. And so still we are paying close to what we thought we should pay before the war. The problem is whether actually your expenditure on health is getting you the results, getting you the satisfaction people get from your health service. Unfortunately, I'm not feeling that, and that's my complaint always to the Minister of Health. Actually, one of our problems is expenditure on health is not streamlined. We pay for health security through another ministry. We pay for medicine separately. Then we pay for medication and also for external medication. So actually we are paying in different lines. And that's one of the things now we're trying to streamline to make sure that we're putting all the money in the right place and we're getting results out of that. And we're moving towards that. It's not an easy thing, especially when you lose most of your sources of income or revenue, then whatever you pay, even if you pay the 30% of your revenue, still you find out that you are far below what is needed to get the satisfaction of the people. So we're trying our best. We think this can be done, and all the ministers of finance should understand that expenditure on education is an investment, and that will help us. And an expenditure on health is an investment, and that will help us all prioritize expenditure on both education and health. That way, I think we can move forward. Thank you.
Thank you, His Excellency. I think you've put it clearly. As you've outlined, this is where alignment between the finance and health, again, you've put in another ministry, which is education, where all three must align together for the betterment and for delivery of healthcare within our continent, Africa.
Absolutely. Actually, these are circles. It's a vicious circle. Unless you make it the positive one, uneducated people cannot take good care of their health. And with bad nutrition, you will not get also good health. And those with low levels of health you have more school dropouts, you have the lower school hours, and again, low understanding in classes. So health, education, and nutrition, they all go together. In Africa, you have the problem of now stunned children who go to school, but they get very little out of schooling. So actually, unless you connect all three of them, you are not going to get the results you are looking for. Thank you.
Okay. Thank you, Excellency. Will now address my next question to His Excellency, Mr. Mark. Excellency, what are the biggest inefficiencies in health spending, and how are you addressing them in your country?
Bon, on aura une réponse assez simple, hein. Déjà, bonjour à tous. Comment le Gabon peut-il intégrer la santé dans son budget, globalement? Donc, Le Gabon intègre la santé dans son budget à travers une approche stratégique qui vise à transformer le financement du secteur, passant d'une dépense sociale résiduelle à un véritable instrument de stabilisation macroéconomique et de croissance. Cette intégration s'appuie sur plusieurs leviers structurels et de réformes de gestion des finances publiques. Je vais vous donner quelques principaux mécanismes par lesquels le Gabon opère cette intégration. Donc, nous avons donc l'ancrage du cadre de dépenses à moyen terme. Le Gabon utilise aujourd'hui le cadre de dépenses à moyen terme comme mécanisme central pour garantir que l'investissement dans la santé est traité comme une priorité macro-budgétaire plutôt que comme une variable d'ajustement. L'élaboration donc de ce cadre spécifique au secteur santé en collaboration avec le ministère des Finances permet de donner une visibilité financière sur plusieurs années pour la mise en œuvre de la politique nationale de santé. Alors au Gabon, nous avons ce que nous appelons le plan national de développement sanitaire qui est élaboré pour plusieurs années, donc de 2024 à 2028. Le budget de la santé est désormais structuré autour des objectifs donc de ce plan stratégique. Ce plan stratégique prévoit notamment une augmentation de la part du budget. Le pays ambitionne donc de porter la part du budget de santé de 11% aujourd'hui à 15% du budget général d'État d'ici décembre 2028, conformément aux engagements pris lors de la déclaration d'Abuja. Nous avons également la réalisation de la réallocation des ressources vers les soins primaires. Donc, le budget est historiquement orienté. Le Gabon donc s'engage à rééquilibrer les ressources en faveur du premier niveau de soins en inscrivant donc des départements sanitaires. Nous avons également une couverture sanitaire universelle à travers une assurance maladie qui est couverte donc par une caisse nationale d'assurance maladie et de garantie sociale. Une part significative des financements publics est allouée au programme national d'assurance maladie. Ce financement repose sur un modèle mixte intégré au budget, à savoir les recettes fiscales et parafiscales et des subventions directes de l'État. Nous pouvons également prévoir le mécanisme donc, de réforme de la gestion des finances publiques. Le Gabon intègre au niveau de la santé à travers des réformes visant à améliorer l'efficacité des dépenses par une budgétisation par programme, également par la transparence des recettes propres générées par le système de santé. Voici un peu quelques orientations mises en place par le Gabon pour moderniser son système de santé et garantir le financement.
Okay, merci. Okay, so thank you again. I can see that Gabon has done extremely well in addressing and meeting the benchmark that is being set. Just as a follow-up question, a lot have been said in this conference room with regards to efficiency of funds. Yes, countries can target 15%, but are we using those funds as efficient to deliver healthcare and health services within our countries? Where do you think maybe resources are being lost?
Bon, il faut essentiellement dire que le Gabon suit une logique de séquencement validée au niveau ministériel par une intégration budgétaire des gains d'efficacité des instruments innovants. Cela signifie que l'utilisation des financements innovants n'est envisagée que si elle est ancrée dans une stratégie nationale crédible et chiffrée et déjà intégrée au cadre macroéconomique. En résumé, il faut dire que l'intégration de la santé dans le budget gabonais ne se limite plus à l'octroi des crédits de fonctionnement, mais s'inscrit dans une planification pluriannuelle visant à protéger les ménages contre les dépenses catastrophiques de santé. C'est pour cela que je disais tantôt que la stratégie gouvernementale aujourd'hui est orientée donc, vers un plan national de santé qui intègre donc la préparation budgétaire et l'allocation de ressources.
Merci. Before I ask the next question, I will just give a little bit of my experience in the Seychelles. I'm currently 6 months in the post of Minister of Health, and my team have already started what we call a war on waste. We've realized that we have such a huge budget when it comes to such a small population, but we feel that we should actually fight against wastage to be able to efficiently use our budget to deliver better healthcare system for our country. So my next question goes to our Excellency here, Mr. Gabriel. Your Excellency, what concrete reform have you implemented to embed health within your fiscal framework?
I think we go back to efficiency again, because actually what we are spending on health is relatively adequate. But as I said earlier, we are not getting the results because we are not spending it efficiently. And I think what you declared is the right wall that every country should do. So, for example, we have around 83% of the population carry the health insurance cards. But practically, when they go to the hospitals or to dispensaries, they don't get much of what they need, service or medicine. So we want to make sure that this card means the health service. It's not just a card. That's one thing. The other thing, we think we need to produce most of the medicine we need within the country. Actually, before the war, we used to produce 60% of our needs of medicine. Unfortunately, most of the medical industry has been destructed, and now we are importing almost everything, and that is creating us a hell of a problem. We need to make sure that we produce the medicine we need, and here I think African countries need to join hands in the production of drugs. Instead of every country investing the same thing, we need to create a common market for it without taxes. Then we all get the right medicine at the right cost. And that will save us a lot of money. The economies of scale in producing medicine. That's one thing we all need to think of in the future. I believe we need to streamline again what we are doing, because at the end, when you spend in different lines and you don't get the results you have to question why you are doing this. For example, the Minister of Defense got its own health insurance. Some in the Ministry of Finance, they have their own health insurance, while we have the public health insurance for the country. And that goes to the Ministry of Foreign Affairs, people in the public sector. So we want to make sure that everybody is there in one health insurance card, not the private insurance the policies while the government is paying. So we want to make sure that we pay in one place and all of us will get the same service, not some have extra privilege in health services. These are some of the headaches now we are facing. But generally, I think spending is important. How much you spend out of your budget on health is important, but also what's the results you are getting out of that are very important. Thank you.
Okay, Excellency, thank you. You clearly mentioned health insurance. In my country, Seychelles, the government fund the entire health budget. And His Excellency, Mr. Mark mentioned that in Gabon, you have health insurance, which is a mixed health insurance and government funding. So how has that really impacted in the health delivery in your country?
Naturellement, l'assurance maladie comme vous l'avez dit, est bien privé. Il y a un fonds privé et un fonds public. Donc, c'est la même structure qui garantit l'assurance pour l'ensemble de la population. Nous avons également un fonds 3 qui est dédié à couvrir les gens économiquement faibles. Et désormais, on va ouvrir un fonds 4 qui est dédié aux travailleurs indépendants, donc la prise en charge des travailleurs indépendants. Donc, nous avons une seule caisse d'assurance maladie qui gère le volet assurance maladie sur l'ensemble du territoire. Voici comment est organisé le fonds au Gabon.
Okay, merci beaucoup. Before we conclude, I will ask you both a final question. So, can you please state one concrete step that you feel your country will take in the near future in terms of healthcare services and delivery?
As long as I am around, I will make sure that my country meets the budget level of expenditure on health. And also, with the help of the Minister of Health, we think we can streamline, and we will try to make expenditure on health more efficient than what we are getting out of it. Thank you.
His Excellency.
Okay. Mais non, en résumé, ce qu'il faut retenir, c'est que l'intégration de la santé dans le budget ne doit plus se limiter à l'octroi des crédits de fonctionnement. Il faut réaliser des choix stratégiques importants, financer l'investissement au niveau du secteur santé et, comme on l'a dit ici, pour qu'ensuite la santé procure devienne une source de revenus que plutôt une source de dépenses.
OK, merci beaucoup. So, Excellencies.
Let me mention one last thing. Actually, one of our problems is health services are concentrated in the urban areas. So there is no justice in health services in the country. And we are trying now to make sure that we are having the same health services all over the country, which is very difficult. It will consume some time, but definitely we have to have the investments in health infrastructure all over the districts and provinces to make sure that all the population are getting the same service. Thank you.
Thank you, Excellencies. Excellencies, it is clear that we can take home some messages from our interaction and engagement. Number one, health must be embedded in a macro fiscal policy. Public financing remains the foundation. Yes. And definitely we can bring in the aspect of health insurance to make sure that the population or the continent is covered. And the most important point is the political commitment of every one of us in this room. I think if we are committed and we unite and join as a continent, the sky is the limit. So thank you, Excellency Mr. Gabriel, and thank you, Excellency Mr.
Thank you very much.
Thank you very much.
Thank you.
Thank you so much, Excellencies, gentlemen, for sharing so much of your expertise, but also for your flexibility. I understand that this was quite an exercise, and you definitely rose to the challenge. The sky is the limit. I think it's a wonderful way to actually, that's what we want to keep in mind and progress in the future to make sure that we offer the best future for the next generations. Thank you once again. So we are now moving into the second part of this discussion, looking at structuring innovative instruments. And this segment is all about the mechanics of mobilization. Our goal here is very simple: identifying what is feasible right now to move the needle on high impact delivery. And to set the scene for this segment, please, let's all join hands to welcome Stephen Karingi, Director of the Macroeconomic Finance and Governance Division at the ECA. Welcome.
Thank you very much, Excellencies. I know we are behind schedule. It's lunchtime, so I'll try, instead of taking the 10 minutes I was given, I'll take a few minutes. I think I was given. So we have listened to the honorable ministers setting us the fiscal foundations of health. And I think what I heard them say is that the challenge that they have is not just the level of resources. I heard them talk about structure of those resources, the predictability of the resources, and maybe, even though they did not mention it in details, maybe the credibility of the health financing systems. Now, but we know that this is the structure, this structure that we have is actually the one that is making many people in the continent spend a lot of money from their pockets. And I think in the political segment, we had how a good number of nearly three quarters of African countries, they exceed the 20% threshold for financial protection, money coming out of pocket. And so from the last conversation, the last question that was asked by His Excellency the Minister from Seychelles, I think we can conclude that the constraint is not just how much is spent, but maybe how the money that is available in the country is structured, pooled, and also anchored in the budget or in the physical systems. So this next part, we are supposed to talk about the structuring of the innovative instruments for financing. And very quickly, I would say the key question is, how do we translate the fiscal foundations that we had from the ministers into financing instruments that can be implemented and sustained in practice? I think that's what this second segment is about. How can we, I think it's not that we do not have the instruments. I think that's the point I wanted to make. In most of our countries, we do actually have the instruments. We know about sovereign finance. We have heard about insurance. We have taxation systems. We even have capital markets. But the question then is, how can these instruments be applied in health financing in ways that reflect the fiscal and institutional realities of African economies? In other words, the fiscal context of each country, and also the institutional reality of each country. Now, I will quickly go to sort of, because I think I want to move things along, talk about 3 examples of what this is about. So let's talk about some country applications. And I have in mind here Ethiopia. Many of us know that Ethiopia is currently restructuring its debts under the G20 common framework. So in the conversation that we are having here, I think the question for us is, how can this restructuring, which of course is being done within a macroeconomic framework, create a fiscal space that can actually be relevant to health. And Ethiopia is not the only country in such a situation, but this panel, this segment, we are supposed to think, how do we sort of create fiscal space of the current macro that we have, part of that macro being the debt that we have, especially for those countries that are restructuring. And I think when that restructuring happens, I think the key thing is that it is possible to create a space for multi-year health allocations within the national budget. And this would be predictable, and it is something that can be done for several years. Another example, and I think it was mentioned in the morning, is the question of levies. We know that levies, excise taxes and solidarity levies, which are instruments that are used in domestic resource mobilization, their strength lies in their stability and predictability, and they can be applied to health to create recurrent domestically anchored financing systems. And I think if I was to talk about a country like Togo, where public financing remains limited, we know that even a modest excise on tobacco, on alcohol, on sugar-sweetened beverages can actually generate millions of dollars. And the key thing here is that this would be a reliable domestic financing base for health. Another example when it comes to the innovative financing is we have heard a lot about blended finance. I think the key thing about blended finance is being able to structure risk so that we can unlock capital. We've heard from the G20 about the issue of the cost of capital and the perception of risk that African countries face. And so if we think about a country like Sierra Leone, using blended finance, we can actually lower the cost of capital, we can address the question of risk, and be able to unlock flows of capital that could be used or could go into health financing. And I can finish by then talking about what our keynote speaker talked about. He talked, Professor Yemi did actually talk about long-term capital that exists in most of our economy. He talked about the pension funds. He talked about a lot of money that is held by insurance companies. And I think institutional investors exist in the continent. And so the question is, how can we be able to unlock this capital held by these institutional investors so we have money to put into health? So in the case of Botswana, for instance, where financial systems are relatively very well developed, there is an opportunity to mobilize a portion of the domestic capital, which then can be built into health. So these are but some of the examples. Maybe I would also have talked about the diaspora bonds, because for countries like Cape Verde and Comoros, they have a very large share of their GDP, almost exceeding 15 to 20% as forms of remittances. So how can we structure these remittances in such a way that some of them can actually go into financing health? So these are some of the questions and examples of the options that we have. The key thing is that they would be country specific. There would be no one size fits all, but the options are there. Thank you very much.
Thank you, Director. Next, to show us how we embed health into that macro fiscal reality to create credible reform pathways, let's now welcome Dr. Alex Ajagba, Senior Advisor and Unit Lead at UNICEF.
Good afternoon. Bonjour tout le monde. Je suis Alex Adjagba, je suis le Global Lead pour l'économie et le financement de la santé à l'UNICEF. Je vais présenter juste quelques slides pour montrer des analyses qu'on est en train de faire avec les autres institutions qui sont dans cet espace. Le mot qu'on a entendu le plus depuis ce matin, c'est incontestablement, c'est le mot santé. Mais si on fait un sondage pour savoir quels sont les autres mots qui ont été utilisés le plus, je crois qu'il y a le mot souveraineté, le mot sécurité financière. Et puis, et donc, je me suis dit, pour commencer cette présentation, je vais... qu'est-ce qui fait les slides, en fait? Comment ça marche? OK. Next one. How do I move to the next one? This one? Okay, thank you. Okay, sorry about that. Yes, it's good. Thank you. So I was saying that we talked about African financing security, we talked about sovereignty, and I wanted to start with this quote. It's a quote from a philosopher from Benin Republic, Paulin Huntonji, who died 2 years ago. He said that for any development process to happen, you have to move yourself from being an object to become a subject. So I think what I want to bring here is a bit of mindset conversation, philosophical and a bit more anthropological conversation. We talked about figures all the time, but you cannot talk about any sovereignty issue or any financial security issue if you don't address the mindset issue, which is a philosophical concept. I want to insist here because every time we talk about global health, we talk about how we lost money, how, USAID was gone, and we all lost 50%, 60% of our budget. But when you talk like that, you are an object of an action that is happening somewhere else. How do you move from that to become a subject? That's what I want to talk about. So you will probably see a bit more of it on this slide. Sorry, I had to change a bit the slide, but hopefully we can go through this. I want to show this one first, talking about being a subject. In 2001, the African countries decided that they would have a 15% target for health financing out of a domestic budget. That's been a subject. But then the question is, how did we do against that target? This slide is showing what we do all the time is to take the target and then to measure ourselves against that target. It's always retrospective. It's always saying in 2025, there were 3 countries that achieved that target. But the question that I want to, when you look at this target issue in terms of subject, you have to ask yourself, where am I going to be in 2030? Where am I going to be in 2063 if we align to the African Union agenda? So that's why we did this. Oh my God, sorry. We did this analysis just to show that in the year 2023, only 2 to reach that target. But if you do what we call a survival analysis approach, oh my God, applied to the Abuja Declaration, sorry, I don't know if you can see that slide well on the corner. It's showing that by 2063, we have less than 1% probability that about 4 countries will achieve that target. What it says is that if there is no major action that is taken, we will meet again and again and again, and we will take the action, and we will just acknowledge that a few countries only are meeting that target. So this 5-minute presentation is just to say that we have an issue that is quite important about being intentional. And being intentional is what you see here. Since 2001, 11 continental health financing instruments were agreed upon by the African Union, by the African Commission, by Africa CDC. There were many calls, and there are calls and calls and calls. So the question is, what is the type of action that we need to have, or instrument that we need to have to make a change? Having only 4 countries, less than 4 countries, to expect to reach the 15% target by 2063 is quite concerning. This is a paper that we are publishing in the coming weeks with colleagues at Africa CDC and at UNICEF. I will jump to the next slide to talk about the fiscal squeeze. So we do know that we have an external funding that has gone down. And then we just saw that the domestic funding in those curves is not encouraging. So this hypothetical, model that we put together was to assess back about 6-8 months ago, if you look at the external cut that happened across Africa, and you look at the magnitude of reduction with regard to the impact on health, what is he saying, especially for UNICEF, especially with regard to the children? So the health consequences are not hypothetical. This is a simulation, of course, but what it's showing is that just for children, we have 80,000 children every year who are going to miss immunization if nothing is done. We have more than 16,000 additional TB patients missing treatment every year. We have 23 million people additional. So basically there was a number of people missing UHC anyway before those cuts happened. We are having 23 million more. And then what it says is that we have this squeeze that is not promising. We have to take actions. What I want to do here is to just say that alongside all the other partners who are working, alongside the country government who are aware of the situation and who are presenting, who are taking action. We've seen action in Nigeria and Ghana, as someone said this morning. We have to, in our perspective, we need 3 key elements. The first one is that decisions need to be based in evidence. We have a lot of evidence in this continent. We have a lot of instruments. We don't necessarily make decisions that are based in on those evidence. And that is also explaining why we are not necessarily raising enough funding for health. So we need to continue developing evidence that speak to the decision makers, that speak to the finance ministries. We need to do a bit more around health commodities, the supply and financing of health commodities, and how they are aligned to the fiscal, cycles, and how much we are doing around diagnostics, for example. How do we inform our planning and our decision making at health facility with a bit more of evidence? And then the last one is about health system strengthening. I will not repeat what was said this morning already around the shortage of health workers and the issues at different facilities. But I want to insist on the partnership that UNICEF has with Africa CDC around pool procurement, around local manufacturing. I think those are a sign that the ownership that we are talking about, the sovereignty issues, are being looked at by different partners, including UNICEF. I will say to finish, that we have those three conditions for a credible reform pathway. We need to acknowledge what has been done as declaration, as as target, but we need to move into concrete support to the countries to make sure that we have costed health plans that are aligned with the medium-term expenditure frameworks. We need PFM support to talk about some of the issues around planning, around efficiency, around absorption. We saw this WHO report, WHO World Bank report showing how little we absorb in our health ministries in Africa. And the last one, as I said, is about health commodities, which is a critical aspect. I want to finish by quoting again. I started with Paul Huntoji, but I want to finish with Samir Amin. Dr. Samir Amin, who was a great African thinker, who really did a great piece of work around thinking of development. I think it's impossible, in my view, to talk about African sovereignty and African health security, financing security, without linking that to frameworks. The epistemological frameworks exist in this continent. We cannot move into a concept of sovereignty and approach it like it's new. Whatever has been done by Samir Amin and others need to be used when we are designing health systems reform. So delinking means building a sovereign project which compels the global system to adjust to it. And I think this project, this initiative here is actually aligned to that. Making sure that we have the knowledge that exists, we have the frameworks, and we have a political will, at least if you look at the African Union declarations. So I hope this is helpful to set up the scene, and I thank you for your attention.
Yes, they found.
Thank you very much, Dr. Ajagba. Before we continue, I have someone's glasses. Does anyone recognize these? Or I'll just keep them and sell them maybe. Times are hard. Let's all now welcome Ambassador Keisha Maguire, Chief Global Affairs Officer at Restoring Vision. A round of applause for Ambassador Maguire. Thank you.
I don't mean to hold anybody up from lunch, but let's get through it together. Excellencies, distinguished delegates, as you all can appreciate, financing instruments do not operate in isolation. They only work when anchored in credible, costed national strategies, aligned with policy and embedded in delivery systems that can absorb and scale investment. So the challenge is structuring financing so it connects fiscal reality to implementation. Health, as we've heard repeatedly today, is not simply a social expenditure. It is a high return economic investment. When structured effectively, it strengthens human capital, boosts productivity, and drives long-term growth. To illustrate this in practice, I'll use iHealth as a case study, drawing on work we at Restoring Vision have implemented with government partners. Let me first provide some statistics. Globally, 2.2 billion people live with vision impairment. And for 1.1 billion of those, it could have been prevented or remains unaddressed. The solutions are simple, highly cost-effective, and proven. Every dollar invested in iHealth generates approximately a $28 return on investment in low and middle income countries. That's a 28-to-1 ROI. Yet, vision impairment costs these economies over $1.1 trillion a year in lost productivity. This tells us something. The gap is not innovation, but rather the gap is how systems and finances are structured to deliver. Eyeglasses can cost just a few dollars to produce, though in many countries they reach consumers at $50 to $200. But when governments restructure those systems, the outcomes actually change. Through Restoring Vision's partnerships with governments, we see this in practice. In Peru, for example, near vision glasses were integrated into its Pension 65 social protection program. In Mexico, delivery was scaled through its national system for integral family development, expanding from a single state to nationwide reach. The result? Lower costs, greater access, national scale, all through existing systems. And this brings us to a critical point. Financing alone is not sufficient. The conditions in which financing operates must first be addressed. Many of the most effective reforms require no new public spending. In eye health, these include allowing over-the-counter sales of reading glasses, classifying eyewear as essential medical devices rather than consumer goods, reducing tariffs and VAT, streamlining customs processes. These are practical reforms that directly impact costs, access, and market function. And they create an enabling environment for delivery, scale, and both public and private investment. With such conditions in place, financing can then be structured to scale for high-impact delivery. A compelling example is being advanced by the Vision Catalyst Fund, working with the World Bank Group on a multi-donor trust fund approach. By combining concessional financing with pooled donor capital, relatively small catalytic contributions can unlock significantly larger volumes of financing for country-led programs, sometimes 3 to 8 times the initial investment. But the critical factor is alignment. Alignment with national systems, alignment with ministries of finance, and with broader health and human capital strategies. This alignment builds sustainability and gives confidence to investors. At the same time, we must be clear about where the financing gap sits. In eye health, it is most acute at the level of SMEs and last mile delivery. And the Islamic Development Bank has been a strong partner in Africa in this regard. Services are often provided informally, limited their ability to scale. This is where the development finance plays a critical role. De-risking market entry, expanding access to credit, supporting formalization, strengthening distribution networks. Nigeria is a prime example which illustrates the opportunity. The President's Vision Initiative, supported by a coalition of partners, in just 12 months, delivered over 1.3 million pairs of eyeglasses through the primary health system, with the goal of delivering eventually 5 million pairs, formalizing last mile delivery and reaching populations previously without access to such care, 66% of whom are receiving eyeglasses for the first time. This is what happens when systems, policy, and financing come together. So let me close with this. The results from Nigeria, Peru, and Mexico are not isolated successes. They are proof points. Proof that when financing is properly structured, anchored in policy, embedded in systems, and aligned with fiscal strategy, delivery at scale becomes possible. And that is exactly what we now have an opportunity to take forward together. On November 2nd of this year, for example, at the inaugural Global Summit for Eye Health hosted by the government of Antigua and Barbuda, countries and partners will come forward with concrete commitments on policy reform, financing, and delivery. More than 80 countries are already engaged, creating for the first time a credible pipeline of investment-ready opportunities in eye health. The task now is to move from concept to implementation. And when we do that, we will not only strengthen health systems, we will unlock economic growth. So the question I leave with you today is, which of us in this room, which countries, which partners are ready to take that next step? The opportunity is here. The moment is now. I thank you.
Thank you very much, Ambassador, for this very powerful call to action. The moment is now indeed. Well, let's swiftly transition to our panel discussion now. So please join us on stage, our moderator, Nikhil Shulani, Managing Director at MedAccess. I'm also calling our distinguished panelists, Dr. Amadou Mustafa Ndiaye, the World Bank's Director for Maghreb and Malta, Haitham El Maïdjeri, Executive VP of Global Trade Bank at Afrexim Bank, Dr. Imed Dream, Manager of Economic Research at the Islamic Development Bank. Joining us also on this stage, Matthew McGregor, Head of Health Finance at the Global Fund, and Dr. Richard Mohigo, Director at Gavi. We are also joined virtually by Mrs. Agnès Soukat, Director for Health and Social Protection at the French Agency of Development. Do we have Mrs. Soukat as well? She should be on the screen very shortly. Director Shulani, I'll let you lead the way. And may I remind all of you to please keep your interventions quite swift as we are working against a very tight deadline today. Thank you very much.
Hello, can you hear me? Try and get close to the microphone. Excellencies, ladies and gentlemen, Africa's greatest asset is our people. Expenditure on health is an investment, and capital reacts to incentives and actions, not to intentions. These are three statements which were made by speakers earlier today and which stood out to me and I think serve to frame the discussion that we're going to have now very well. So good morning, my name is Nikhil Chulani. I'm a Managing Director with MedAccess. MedAccess is an innovative health financing organization that was established in 2018 by the British government through its development finance institution called British International Investment. Over the last 8 years, MedAccess has worked to structure innovative financing agreements, primarily through volume guarantee agreements, but also through funded loan transactions in order to make access to critical life-saving vaccines, medicines and diagnostic services more widely available in Africa and other low-income and underserved markets. I myself was also raised in West Africa, in Lagos, Nigeria, and so the topic of improving healthcare in Africa is very personal to me. Now we've just come from a very powerful discussion on the fiscal foundations of sustainable health financing. And the central argument that emerged from that was innovative financing instruments are only viable and effective when they are grounded and connected to multi-year national health strategies which are fiscally credible. And without the integration of individual investments into macroeconomic frameworks and public financial management systems, instruments such as blended finance vehicles, debt for health swaps, and ESG-linked bonds risk to become isolated transactions rather than structural solutions. So this much is widely agreed. So the purpose of this discussion that we're going to hold now for the next, I'm not sure exactly how much time we have left, initially an hour, but maybe slightly less than that, is to take the discussion further. And we will attempt to move beyond this conceptual agreement into more specificity, including relating to identification of priority instruments that are immediately actionable and a clear articulation of what has worked and not worked, including innovative structuring financing in the African context. So I'm delighted to be joined by a distinguished panel today. Maybe if I could just ask from just brief one-line introduction of each of you, and then we'll come to questions, starting with you.
Yeah, thank you very much. My name is Dr. Richard Mohigo. I'm from Gavi, the Vaccine Alliance, and I'm the Director for Advocacy.
Good afternoon, everyone. Matthew McGregor. I'm the head of the Health Finance Department at the Global Fund. It's wonderful to be part of the conversation.
Hello, my name is Haitham. I'm the Executive Vice President of Africa Bank, Africa Export-Import Bank.
Good afternoon. I'm Amadou Mustafa Njai. I'm the World Bank Director for the Maghreb and Malta, based in Rabat.
Assalamu alaikum wa rahmatullah. My name is Imad Deen. I'm Manager of Economic Research from the Group Chief Economist at the Islamic Development Bank.
Thank you very much. We'll start with you, Dr. Ndiaye. So the World Bank has seen what happens when innovative instruments bypass rather than integrate with national budget systems. You've seen the failures in practice. So my question to you is, what are the core elements that must be in place to allow for these instruments being discussed today to be deployed effectively?
Well, thank you very much, and thank you for the organizers for inviting us to share our experience. I think the discussion today has actually highlighted a lot of the issues, whether it's about financing, whether it's about execution. And so I will refer to some of these issues that were identified earlier. The question really is, there have been a lot of recommendations. The question is, how do we get there? And I think we all will agree that we need to make a better use of existing resources. Resources are scarce. There are probably different options, different instruments that were mentioned to increase the level of financing for the health sector. But I think what we need to do is really to start with the scarce resources that we already have. So we agree that we need more money, but more money alone will not fix the health system. The question really is, what is as important as raising more money is how government plan, how they allocate, how they execute, and how they account for health budget that they receive. I would like to leave you with 3 key messages. The first one really is the need to move from the logic of control to the logic of results. The second message is to execute the budget allocated, even if it is not enough. I think it was mentioned earlier, the limited budget that we receive is not fully executed, and I will come back to that. And the last message that I would like to leave you with really is how to ensure that the money that we have is actually reaching the front line, the services, the delivery. So on the first one, I think the core problem is the logic of control, not results. When we look at the most current public financial management system in many countries, they were designed to prevent fiscal risk. They were not necessarily designed to achieve results on the ground, not enabling service delivery. Funds are allocated by inputs, salaries, supplies, rather than by outputs. So a lot of effort is now being done to move to program-based budgeting. And at the World Bank, because we are here in Morocco, we have a big health program. It's a program for results, where we disburse based on results that are achieved. The second one is execution. We see very often that budgets that are allocated to Ministry of Health are not fully executed. Our estimates show that there is an average of about $4 per capita of health budget that's not executed. That's the equivalent of the total primary healthcare spending. So I think a lot of effort really need to go into improving the budget execution. And the last message really is funds must reach the front line. Even when budgets are allocated and executed at the central level, money often fails to reach primary care facilities due to decentralization challenges and a lack of explicit primary health care allocation mechanism. So at the World Bank, we do advocate for establishing dedicated budget lines and direct transfer mechanisms for primary health care facilities. I think if we implemented well these 3 key messages, we will have a better efficiency. I think there was a call for efficiency of the budget allocation to the health sector.
Maybe just one follow-up question for you, Doctor. If you could talk through some of the risks you've seen with off-budget financing that we've seen historically.
No, thank you. I think this is a very important question because very often what happens if you want to protect certain priority sectors, we tend to create a standalone account of budget allocation, such for the health or vertical funds. What we have seen is that when health financing flows outside national systems through parallel project implementation unit, through earmarked donor funds or fragmented vertical programs, definitely in the short run, we can achieve results. I think the challenge really is how to sustain those results. One of the challenges that we see is having this off-budget financing mechanism can actually lead to increasing the operating cost. We employ more workers. We do procurement that are outside the government system, and these costs cannot be sustained. I think this is a major risk. And one of the things that was also mentioned earlier this morning is really the need for all of us really to work together. Because when resources are scarce, I think there is a call for efficiency. I think if you reduce the cost, the transaction cost, but by reducing the transaction cost, we really need to work through the government systems so that we are already around the national systems. So off-budget financing is actually going against these needs to work around the government system and strengthening them.
Thank you very much. Maybe, by the way, we've also been joined by Dr. Agnes Sukat from AFD. So thank you so much. We'll come to you shortly. I think next we'll turn to Afrexim. And a question for you, sir, is given Afrexim's experience at the intersection of development finance and capital markets, and your understanding of what institutional investors need before they will put money into health-linked investments, could you elaborate on one innovative financing instrument that you believe is executable within the next 12 to 18 months, and what would be required to make it work in a specific country context?
Okay, so let me explain quickly how we should think so that we can design correctly for this. One is the issue is not lack of capital as such, because you have a lot of projects that you see, but at the same time, you have a lot of funds that have interest in Africa, appetite in Africa, but standing there and wondering what to invest in. So the idea is how come we have every year here, not only health, trade, 40 billion, 80 billion, depending on what you look at, and at the same time, people whose interest in it's not matching. It's basically, we have a lack of bankable projects, a projects or health system that is a good idea, but it's not speaking the investor language or the bankability language. It's not structured the way they would like it. It's not touching the appetite and the way they put their money. So the whole thing is to bridge this. The second thing is, if you want to increase the capital pool, Africa needs to know to push health, or to push any investment, they need to have bigger banks. So Afrexim Bank with like $45 billion balance sheet, you need bigger Afrexim banks, more Afrexim banks. Look at how China and the US have the size of their banks that carry the economy compared to the size of banking system within Africa. So ideas are a lot, but if you want to go aggressive, we should think about something that a bit of more of creating a dent, so to speak. So you see now, for example, different parties on the game when you want structure. You see the obligors or the hospital, the healthcare center and the whole thing who needs the fund. You see the off-takers who are the people who are paying them, mainly the government programs, the corporate health insurance system, all of these consumers that generate revenue for them, and then the investor at the rest of the triangle. we can collectively look at how can we put a portfolio of those people in one SPV or one fund, all revenue generating healthcare initiatives that will help support those who can pay and also carry along who cannot, make sure that we are ring fencing correctly and put the right of takers, which is the government, the corporates paying for insurance, the whole thing, so that we make sure that this is a fund that has a revenue stream to interest investors, and then ring fence it carefully, put guarantees, put repack structure around it, make sure that it's at the level of investment grade that the investors would like to see, and then sell it to the pension funds, the investors, and so on. So it's somehow, I feel, if we really want to make a dent, let's start to think of funds, let's start to think of SPVs, let's start to think of creating asset class for investors, because there are a lot of people with appetite in Africa, but they do not find the asset class that might tick their box when it comes to what they can invest in. This is one thing, but you can do a lot of other structures, but just in terms of how we should think, I think we should think end user and design from there.
Thank you. And maybe just one follow-up question. If you could elaborate on something specific Afrexim has done in the last few years in the field of mobilizing private capital, ESG.
Yeah, so we're very active in this. So if you remember during Corona, COVID-19, we have a pivotal role within the content. The content has two issues. One, securing the money to buy the vaccine, to actually buying the vaccine. If you remember this time, a lot of protectionism has happened. People don't want to sell their vaccine outside of their borders. So we managed to put a big facility, we call it the PTIM facility, where we deployed large sums of money to each country to buy their own vaccine, together with support with our partners, and also negotiate on their behalf mass buying. And this was one of the major dents we managed to help the African continent. And this time, we currently invest in what we call Africa Medical Center for Excellence, which basically started in Abuja, where we put large medical centers for R&D, for research actually on African-specific diseases rather than general global diseases, and also to maintain the African talents within the continent, because they are migrating, because they don't have facilities that they can carry and progress within this, and several other instruments. And we do either a large direct investment like these ones, or we do now in the digital world, where we're doing a marketplace to buy and sell, and allow people who has access, when talking about optimization, to African countries to talk together and source from each other. And we're using a lot of tools around it, de-risking, guarantees, the whole thing, or we do direct funding for those. But we have, in addition to our normal funding for health projects, we have a number of major initiatives that make a difference to our member countries, our shareholders' member countries.
Thank you very much. Maybe to our next speaker, I'll bring in Dr. Agnes from the screen. Dr. Agnes, welcome. My first question for you, I think, draws on your and AFD's hands-on experience designing blended finance vehicles and results-based financing structures. So maybe just a simple one to start off. If you could share with us some of your experience and lessons learned from how AFD has designed such blended finance vehicles and results-based financing structures, please.
Thank you very much, and very nice to be able to join you, even if it's only virtually today. I think what as we stand here, a quarter of the way into the 21st century, we've been living through more than 100 years of spectacular improvements in human health, as well as more recently, about 40 years of unprecedented increases in health spending at both global and national levels. So health spending now represents about 10% of global GDP, with about 60% being public. And development aid is important for some very low-income countries, but overall it represents less than 0.3% of total spending on health. So most of what is happening in health today is driven by the market forces and the investments globally in health technology. Economic growth technology, education have fueled demand, while progressive institution and government capacity building have built the supply side. So spending on health consistently has increased faster than economic growth, reflecting the strong demand by people, and it has become increasingly more public when it comes to its financing source. But to respond to your question, the sustained improvements in health outcome and increase in domestic spending do not represent this whole picture, because the two recent events, the COVID-19 and the withdrawal of the largest donor recently with the closing of USAID, has actually shown that the relative abundance of resources for health has papered over cracks in health financing systems, and likely, in fact, made the cracks deeper and more structural because they were masked by the increasing resources. And what we've seen is that the overall debate on global health financing has often been divided between a debate on the mobilization of grant resources through global health initiatives, aka the Global Fund or Gavi, and on the other hand, the mobilization of more blended type of financing using different financing instruments through development banks and through the development sector. This sort of 0-1 type of approach is not the reality. What is happening today is the demand for countries, we've seen it post-COVID, for investments that build the sovereignty of countries in the development and the financing of their health services and their supply chain of health products. And for that, what they want is more liquidities, more investments, and better terms to mobilize this money. And these better terms, they can be only obtained if we mobilize all the sources of financing, all the different instruments, and the entire community of financial institutions. So this was mentioned by the World Bank and by Afreximbank, but now if we think about the capacity to invest of public development banks, there are more than 550 of them today. It's 2.8 trillion per year. It's 10% of total investment. So that's just public development banks. And then you have private sector investments. And the essence today is how to mobilize that amount of money, which really dwarfs whatever is available in terms of overseas development aid or development assistance for health. And the point is that, yes, there is the issue of the amounts of money, of creating a space for more investment, but also the issue of the cost of this money, the question of debt and the question of mobilization of concessionality. And today, clearly, the shock of COVID that has shown that the question was not only money. Money has been mobilized largely by financial institutions, but actually that money fell on a market that was not ready to step up its capacity, to step up its production. And that's what we need to build today. And for that, we will need to marry the different instruments and bring concessionality more in sync with the other financial instruments. So when we talk about blended financing, this is really what we've been doing as a coalition of public development banks, and particularly with the European Commission and the mobilization of grant financing from Europe, activating a coalition of both development banks that includes AFD, but also other development banks, including the European Investment Bank, including the World Bank, including Afrexim Bank, and bringing together the grant aspects and the blended and the lending as well as the guarantee instruments, so that we expand the amount of liquidity and we provide more long-term, more concessional financing. And one of the success has really been the investments in the sovereignty of production of medical products, with large amounts of financing being mobilized both for developing a pharmaceutical sector, as in the case of Senegal, for example, where we have this coalition of both development banks and donors who provide large amounts of grants, who supported budget support, investments, as well as projects to support the production of vaccine, but also projects that support regulation institutions that can work in the overall creating the framework for investments in the production of medical products, projects that invest in R&D, and projects that directly invest in the private sector, such as the financing of Aspen and Biovac in South Africa. And we are now having a growing and vibrant pipeline of investments in the pharmaceutical sector in Africa. And I think that's really one of the key elements for that is really bringing together all sources of financing, that the lessons from the crisis, the COVID-19 crisis, as well as now from the very rapid shift of the modalities of support from donors, particularly US government, tells us that it's time to really bring together some consolidated ways of investment that increases the concessionality and leverages the investments in health services, in health systems, through expanding the pot of financing and mobilizing all financial instruments, both public and private. And there are some mechanism around. I mentioned the European one, which we are very much part of, but certainly the pandemic fund also in the World Bank, which we co-fund as the French government in European countries, is also a good examples to show how you can have grant financing of global public good that actually provide concessionality to countries for them to borrow, to invest in health. And that's really one of the, in our view, one of the most promising way we can reorganize the global financial infrastructure in global financial architecture, so that we can make it work for health, in bringing together the different mechanisms that and leverage both public financing and private financing. Thanks.
And yes, I might just, to make sure we can go around all the panelists in time, I might turn now to our members who are representing the two organizations which are purely health-focused organizations, Global Fund and Gavi. I'll start with Matthew McGregor from the Global Fund. I would appreciate if you could maybe share some lessons learned from your engagement on innovative financing instruments, as well as some guiding principles that you think can help us turn these from theory into reality with some examples, if possible. Thank you.
Great, thanks, Nikhil. So first, just let me say thank you to ECA. It's a real privilege to be able to be here and participate in the discussion and listen to all the perspectives today. As so many people have said, you know, the forum is coming at a time of really growing financing challenges, with really significant pressures on health systems. And as one of the largest providers of grants to the health sector, with more than 70% of our resources focused on Africa, we're really committed to being the best partner we can be as African countries address those challenges, strengthen their own financing of their own systems, increase self-reliance, all of those themes we've heard about throughout today. And we do this in a number of ways. We do it in how we leverage our grants to encourage countries to invest in health systems. We do it through our investments in public financial capacity. We do it through the types of investments we make in health systems building blocks, domestic financing advocacy, and through these more innovative or alternative financing mechanisms. Before I answer your question, Nikhil, and I just want to make one point. At the Global Fund, I lead our support for health financing overall, as well as innovative and financing modalities. And I think we just have to be clear as we have this conversation, which is that we've got to think of innovation and financing modalities as a complement to the core. There is really no substitute for core improvements that a lot of the speakers have talked about over the course of this morning. Improved allocations to the health sector, better public financial management capacities, more revenue raising through taxation, less dependence on external financing. Those are the types of things that can really move the needle as we think about how we're going to strengthen health systems. The innovation, at least in what we support, really has to be complementary to that. And when it is complementary to that, it can be really, really valuable. So to get to your question, Nikhil, on what of some of the guiding principles or lessons learned we've seen. Many of them have already been mentioned by speakers, so I'll be brief. The first is making sure that any discussion of financing mechanisms fits within fiscal context and embedded national health strategies. These things can't be parallel or one-off so much as part of an overall thinking of how we finance the health system. The second I would mention that hasn't come up is strong implementation platforms. A lot of times when we're generating resources through innovation or innovative mechanisms, we need to find the mechanisms through which we'll implement them and through systems that can absorb them, track them, and deliver results. And we've found that making sure that those are not parallel, that we're not creating new things when we come up with a new mechanism is really important. The third I'd say is clear country demand and clear programmatic need, and how we're matching the mechanism to the clear demand and the clear programmatic need. This is a bit of the thinking that innovation and these financing mechanisms are really a means to an end. This isn't a hammer so much looking for a nail, rather than thinking, what are the specific programmatic needs or health gaps that could be addressed by a more innovative mechanism? And really aligning that is quite critical. And then the fourth I would mention is really strong alignment between partners. There are a number of these mechanisms where different partners have to play different roles, where one could say be an implementation platform, another providing a guarantee, another working to structure a transaction, and strong alignment up front as something that we've seen has been really valuable. So if I think about that, we support a whole variety of innovation that has come up this morning. Pooled procurement mechanisms, the way that supporting countries to move more toward pooled financing. But I want to use a couple of examples that I think are probably valuable for the conversation. The first is around debt to health. Debt swaps has come up a lot. And this is one of the things we've been working on for quite a while. We've worked very closely with creditors and countries to convert external debt into domestic health investments. We're one of the entities that has been really focused on this historically. And there's evidence that it works. We've done 14 of these investments, and we've converted about $500 million worth of debt into about $360 million worth of health investments, including here in Africa. So for example, we did a Cameroon debt swap that canceled about $25 million worth of debt and invested about $11 million in very specific programmatic needs for ART treatment. In Ethiopia, we did one where we reinvested the proceeds in strengthening laboratory systems and surveillance capacity, really showing how these can build on some of the systems building blocks. And one of the lessons that we've learned about this, and one of the reasons that it's been successful, is it's aligned to many of the criteria that I just mentioned. There's been very clear country demand for these. There's been scalability, not creating them for just one country, but the ability to create them for multiple countries. And then rather than using new implementation platforms, all of the resources that have been generated through those platforms have been invested in the same systems that the Global Fund uses across all of our portfolio. So we can really invest in nationally owned, country-owned strategies that countries have decided and simply channel the additional resources to them. So it really fits. I think the only other example before I close that I would mention is the increasing work we're doing with entities on this stage, including the World Bank, and thinking about how we try to combine the grant resources we have much more frequently with concessional lending of development banks. That might not sound that innovative, but it really does align with what countries are calling for in terms of help us align around a common platform to invest in national health priorities. So a couple of examples: in Côte d'Ivoire, we've made a joint investment where the bank was investing in a much broader project, and we were investing in national malaria programming and scaling up a performance-based mechanism for malaria programming, as well as supporting health systems reforms. That was not something that we could do on our own. It made much more sense to do it in a combined platform. In South Sudan, for example, we've made a very significant investment in a joint platform with many partners designed to expand malaria coverage. And it's not something that we could do on our own. So I think when I use those examples, I'm really going back to that principle I mentioned about aligning the partners up front and thinking about where each one can have their value added. So I hope those are some of the principles and lessons and some examples that I could offer to the conversation.
Very, very valuable. Thank you so much. If I may now turn to Dr. Richard from Gavi. I think Gavi's been very active recently in this agenda, and I think the African Vaccine Manufacturing Initiative has injected a lot of life into that sector. So maybe if I could turn to you to maybe share your guidance and kind of key principles for us, building on what Matthew said.
Yeah, thank you. Thank you very much, Nikhil. I'll be very brief. Yeah, maybe before I elaborate more on AVMA and why actually we took that decision to move into that direction. At Gavi, we are working on immunization. And unlike many other organizations, I think for immunization, at the core of our mission, actually, we put forward the country contribution themselves. One of the key features of our support to countries is the co-financing. As we invest in strengthening immunization in primary healthcare in countries do contribute themselves on their immunization program. In our next 5-year strategic period that's starting this year, we are expecting countries to contribute up to $4 billion of their own resources to immunization. So I think this resonates quite very well when we heard since this morning about health is not necessarily only a expenditure, it's really a real investment. Now, coming back to your question, we did learn the hard way, actually, after the COVID-19 pandemic, how, particularly on this continent, many countries were actually left out on the access to vaccine. And we heard statistics that are not necessarily good this morning from the DG from Africa CDC. Only 1% of the vaccines that are being used in Africa are produced in Africa. We took that opportunity to see how we can contribute actually to this new process. There is a new financial instrument that we launched a year and a half ago called AVMA, the African Vaccine Manufacturing Accelerator, which actually is going to, it's a $1.2 billion financial instrument, going to provide incentive for local vaccine manufacturing on the African continent. So this was an opportunity for us to contribute to the ambition of the African member states to produce at least 60% of their own products by 2040. So the way it is going to work, very briefly, it's by providing incentive to local manufacturers on the continent, by providing what we call milestone payment to help to de-risk some of the investment before the manufacturers on the African continent become competitive, not only on the continent, but also on the global scale. And as well in this, let's say, ramping phase, to provide a bit of subsidy to some of the vaccines that are produced on the African continent, so that we can purchase those vaccines directly from the African manufacturer. So we have seen some progress which has been made. We, by the way, working with MedAccess to try to make this happening, particularly on the payment, milestone payment. Seeing some progress in terms of technological transfer to local manufacturers on the continent. We are seeing some commitment to a subset of product that could potentially enter the market in the near future on the continent. And we are really eager to see that becoming a reality and starting to purchase vaccine that are actually made locally on the African continent.
Thank you very much. We'll see if we have time to come back for follow-up questions, but I just want to cover the last panelist we haven't yet heard from, Dr. Imed Drine from ISDB. So Doctor, my first question to you is if you could maybe just introduce some of the key alternative financing structures which have Sharia compliant modalities and how these can complement other innovative financing pathways which we have discussed.
First of all, thank you very much, Mr. Chairman, and I would like really to thank UNICA for giving us this opportunity to be part of this panel and to contribute to this conversation around how we fill the gap in the health sector. And I will address it from the perspective of the Islamic Development Bank, which is really an MDB, using the Islamic finance as a tool to address development challenge in our member countries. Now, from the perspective of the Islamic Development Bank, as all MDBs, and we have a strong collaboration with all MDBs, including the African Development Bank, the World Bank, the World Health Organization, and so on, is that we try really to look at a different perspective, how we can really deal with the tight constraint that our member country are really dealing with in terms of finding enough fiscal space. And we know that the scope is very limited in terms of reallocation. So we work on different kind of areas, including, first of all, how we can help our country leverage the new technology to improve efficiency in terms of using their fiscal budget. There are also, we have some kind of mechanism and tools where we can also try to make some saving in terms of transferring the knowledge, particularly in the health sector. And we have been very successful in running a certain number of very successful project in different countries. The most recent one is the telehealth, where we tried really to establish an ICU, intensive care unit, in collaboration with Egypt and Indonesia in Somalia. And this is supposed really to be serving around 700,000 people. In addition to all of that, of course, we try to mobilize additional financial resources using innovative tools, particularly Islamic finance. Here, what I want really to mention is the fact that Islamic finance as a tool to finance health is not something experimental. Is a proven solution that it is already delivering on the ground. And we have been, that's been helping a lot of our member countries in different areas, particularly in the health sector. Now, if you look now, try to explain why we really need to scale up rather than, we do not really consider it as innovative solution. It's really a proved solution that we need to scale and to align more with our financing strategy at the national level. Now, if you look at the Islamic finance in terms of nature and in terms of objective, it is very well aligned with the objective of justice, solidarity, compassion, and the respect of human dignity, which is well aligned with the health sector. The other thing is the fact that Islamic finance, because it is based on risk sharing, and it is a setbacks kind of financing. It is very well suited for infrastructure investment in the social sector, particularly health and education. And so from this perspective, we look at it a very good candidate, ready to contribute more to the health sector. And other thing is that we see that in growing demand when it comes to impact-driven investment. And a lot of my colleagues already mentioned diaspora, and diaspora in general, they are not really concerned about high return, is more concerned about developing impact of their contribution, and particularly when it comes to health and education, they are already contributing to health, and the out-of-pocket in general, they are coming from the diaspora and immigrants. So from this perspective, the Islamic finance can back this needs. The other thing is that if you look at the Islamic finance industry, as 2024, it's around $5.5 trillion and expected to be around $7.5 trillion in 2028. The contribution, if you look at the contribution of Africa in terms of sukuk issuance at the global level, is just 2%. So you can see that it is really very significant pool of capital that we can tap in really and to channel toward more social sectors. Now, we have some kind of experience because Africa started really using issuing sukuk, for example, which is one of the Islamic finance product, in 2014. So far, we have around 6 billion issuance. The leading country are particularly South Africa, Egypt, and Nigeria, and very recently Benin. In 2026, they issued around $500 million in sukuk. Now, this gives an idea that there is a growing interest in alternative financing that is really very scalable, and it is already showing a lot of impact in terms of social outcomes. Of course, there are a certain number of conditions for this really to work and to deliver impact on the ground. For example, it should be integrated in the national financing strategy and policy. It should really, it needs in fact a kind of governance arrangement that will ensure transparency, accountability, regulatory supervision, and so on. And it should really be based on what we call impact, measurement impact in terms of health. If all these conditions are met, we can see that in many countries, Islamic finance already contributing to the health sector and other sector, particularly education. Now, if you want to elaborate more about what we can do at Islamic Development Bank in the area of Islamic finance, that we can help our member country to benefit more from this untapped resource that we consider huge, and still there is a lot of potential to use. We are working in our member country, in different member countries, in terms of the regulatory and legal frameworks, so it can really accommodate the Islamic finance. We are working in terms of technical assistance and capacity building to help them to understand better how it works, how we can operationalize Islamic finance. We work with them in terms of project preparation, so that can be really attractive to the foreign investor, private investment. And we work with them also in terms of providing the right incentives for investor really to tolerate more risk in a number of sectors, so they can benefit from this. So we have a certain number of initiatives in this regard. If you would like, I can just share with you some examples of these initiatives. One of them, I mentioned it already, the telehealth. This is really how we can leverage digital technologies and try really to make health services affordable for the underserved population. And it is already running in many countries in the world, and in Africa, we are already working with the Somalia. I mentioned this. The other one, we very recently we engaged with the World Health Organization to support a new platform for impact investment with around $10 million. And we are aiming in collaboration with the organization to mobilize around $500 billion for primary health care and building health facilities. I would also like to mention the fact that we have a specific mechanism, because as Islamic Development Bank, we are covering 57 member countries from Central Asia to East Asia to Middle East to North Africa to Sub-Saharan Africa to Latin America. And as an international organization, we are from the south to the south by the south. So all our member countries are from the south. So we have this kind of wealth of knowledge that we can mobilize to transfer some kind of very successful ways to improve service delivery in the health sector through a mechanism called reverse linkage, where we put our money as grant money, and this grant money are supporting the transfer of this knowledge. And I want to end by mentioning very recently we established a new concessional window. This concessional window is really targeting mainly the social sector, particularly education and health, where we want really to provide affordable financing to our member country so they can address these challenges. So just to say that there are a lot of opportunity that we can benefit from, and as Islamic Development Bank, we stand really ready to support any request coming from our member countries. Thank you.
Thank you so much. I'm just conscious of time. We have time for one more round of questions? 5 minutes, yeah? Brilliant. So I think, Doctor, I think you've, Dr. That theme of there's so much we could do is where I want to take the next and final question. Just the same question to all the panelists. We'll just go one by one. We'll start at this end and work down and finish with Dr. Agnes on the line. So the question is, of all these mechanisms, instruments, initiatives, which we're all working on, if you could choose one which you think is most actionable over the next 12 to 18 months, and which your organization can make some specific commitments towards, what would that be?
Well, it's a very interesting question. Definitely, I will pick AVMA. AVMA, because this is our core business. The African vaccine manufacturing is not only a project, it's something that we have already taken forward with member states. This is something that came as a result from the demand from countries themselves to respond to a very clear need on the African continent, responding and supporting initiatives that are born on the continent. So we are looking forward. We are working with the African Union. We are working with Africa CDC, WHO, UNICEF to make this happening. And we are expecting to see the first vaccine that are manufactured on the African continent supported through this instrument in the next couple of months, we hope so.
Looking forward to seeing the progress there.
Yeah.
Mr. McGregor, over to you.
It's a good question, Nikhil. It goes a little bit against the principle of making sure that any of these discussions are about country context and embedding these instruments into countries' national planning. I mean, I think we have to answer this question with recognition that there are no silver bullets here. There is not one mechanism that is going to substitute for a more comprehensive way that we need to improve financing of overall systems. So with that caveat, I mean, I would say I do think that there are opportunities to increase the use of debt swaps in the health sector. We've seen the use of these in other sectors heavily, include particularly in the climate sector and in the conservation sector. And if we think about the confluence of factors, the very large amount of debt that exists, the interest and demand from countries to be thinking about how we can channel some of that into the social sectors and in the health sector, and the increasing conversation around it, including even this morning, I do think that that's something that we have to seize. I think we have to seize it, though, as I said, within a broader framework. Even if we're successful in using debt swaps to support health sector priorities, it won't necessarily fill the gaps that we know will come from increasing health sector allocations, increasing efficiencies. So, but I do think that that is an opportunity, and it's something that, given the building conversation and the good examples we have out there in other sectors, we should be thinking about.
I think we need to find a way to industrialize the way we can obtain faster funding for what we do. Because there's a lot of good things that are happening, like the debt swap. Some people go into health tax, some people look at health bonds, diaspora, but you feel it's a bit of sporadic because it fixes one country while you have 50 plus other countries waiting for the return. And I'm not sure how can we collectively start to think of bigger instruments that collect the need somehow or the patterns, float funds, get investors, de-risk those funds, put an investment grade layers on it, start to do more mass funding so that we can use those different instruments in a way that we can help more countries faster. Because we see it ourselves, by the time you deploy one instrument after another, it goes through the legislation, the paperwork, the legal framework. Like there are a lot of people waiting and it's not happening fast enough. We have to understand the size of the problem and the number of people who don't have healthcare within Africa, and the number of people who, even solving something as simple as energy crisis, where you have half of the continent don't have access to proper electricity, and 400,000 or so but dying because they're burning wood in their home to cook. So this is a preventive health measure that we need to look at, even on what are we doing about all of these people dying because of this, and the rest are in very bad shape in terms of health. So I think maybe it's time to think of something big together in terms of funds, de-risking, deploying more funds faster, and so on.
Thank you.
Well, I think we probably need all of the instruments, as we say, all of the above, because not all the instruments work in all contexts, and also just one instrument will not help address all the issues. So I'm hoping that collectively we can find a new instrument that we can develop and promote so that we can go at scale. As my friend from the Islamic Development Bank was saying, you know, many of these instruments are not new. We probably should not be necessarily talking about innovation, but how we can scale them. Yeah. So if there is one that I would really want to focus on is maybe building on the recent example experience we had in Cote d'Ivoire on the debt for development swaps, which provide more results and more debt. But it's not just about having debt for development swap. I think it's also about linking it to results, because what we have heard throughout this morning is how we can get health outcomes. So a lot of discussion about this debt for development swap. There are also risks associated with it, which mean that we need to develop it in a very structured framework. And this is where the World Bank has been working with the IMF jointly to have this debt for development swap approach framework that offers a structured, lower transaction cost model for converting expensive debt into a development outcome. And we have actually used it in Cote d'Ivoire recently, using a World Bank policy-based guarantee, together with a guarantee from the World Bank Group Multilateral Investment Guarantee Agency. The government of Cote d'Ivoire was able actually to convert more expensive loans into into the education sector, saving on the way $60 million. And these 60 million were partly recycled using a performance-based financing into the education. So this really showed that it can be done, but the question is not whether we should do it. The question is how we can take it at scale.
Thank you. Thank you very much. It's a very difficult question because given how important is the gap in terms of financing, one instrument will not really be addressed. This gap, and we need really to be aware about the complexity of the issue. And with all this result that we saw this morning and the needs for the future, it is really an important challenge. I think it should be kind of combination between different kind of tools and instruments, including particularly, and this is the area that we try to work on more, involvement of the private sector and using of new technology to make health services more affordable for the underserved population. And here we see a lot of scope for improvement. Very recently, we worked in a new product which is called Diaspora Sukuk. And we think that there is a segment of population that currently is not really very well tapped in, which is diaspora, and we see a lot of interest of diaspora to support the development objective of their member country. Unfortunately, they could not really find the right product, and sometimes also about kind of relationship and trust building that we need really to work on. I think private-public partnership is really very promising area that we need to look at it very carefully. And we see how we can, that's been divided the responsibility between the public sector and the private sector, that the private sector also from social perspective, they can play their role because as we said, it is not only about productivity, it's about the dignity and it's about human rights. So everybody is supposed really to contribute. From Islamic perspective, we are trying to work more on waqf. Because what we consider is really very promising and it showed a lot of impact in terms of providing affordable services. And we try to combine these with Sukuk and see if it can really come up with the kind of instrument that will interest foreign investors. So there are different areas that we are working on. Let's hope that we will come up with something that will make some kind of contribution to this important debate around financing health sector. Thank you.
And finally, Dr. Anyas.
Thank you very much. If I really have to choose one initiative, I would really say that we need to really join our forces to continue, expand, sustain the initiative on sovereignty of production of medical products in Africa. It's been actually an incredibly successful initiative in terms of mobilizing funding from different sources and mobilizing blended financing. From the European perspective, this has been the Team Europe approach with MAF Plus and the investments, as I mentioned, in different countries of Africa with major investments in South Africa, Senegal, Rwanda, Ghana, etc. This has been a mobilization of all public development banks through the coalition of finance in common and the DFIs, the G7 DFI initiative. It is both mobilization of public and private money. And in my professional life, which now is getting a bit long, it's one of the fastest, most successful mobilization of funding. And of course, there were reasons for that. It's because of the scale and the shock of the COVID-19 pandemic. The fact it's been mentioned that the markets and the global architecture for health did not work to deliver vaccines on time. And it was not a money issue. It was really a lack of anticipation in investing in production and supply chain. And now the global community has rallied around that. There is a very strong partnership, both between the European Union and the African Union on that. And there is political commitment. There are more resources coming through the global gateway from EU. And there's also more coming from development banks, particularly with the new World Bank initiative, the AIM initiative on investments in the pharmaceutical sector. I think we should really collectively take this challenge on for the next few years, or really building a vibrant industry of production of medical products in Africa.
Thank you so much. Thank you so much to all the panelists. Thank you, echo all the thank you to the UNECA for hosting us and prioritizing this discussion. And the last thing I'd say, maybe just to three words which I think came across from all the panelists today, summarizing the discussion, if I had to choose three: scale, not just innovation, even though the title of the panel was about innovation, but I think it's a very valid and important point that scaling existing solutions is as important as innovating new solutions. Cooperation and the importance of working together to be able to achieve at scale. And then thirdly, and I think this resonates with the closing words from Dr. Keisha from the previous session, is really urgency. I think all of us in this room, from our heart and our mind, know that it's absolutely the case that the opportunity and the need is now. And so it's up to us to scale and incorporate our efforts to achieve these health outcomes. So with that, thank you all very much for your time and your patience. I know lunch is waiting for all of us. We'll close here. Thank you, and thank you once again to all the panelists.
Well, thank you very much, gentlemen, and Mrs. Sukat on the line. Oh, okay. All right. So now I would like to call our last speaker just before lunch. Don't worry, lunch is just around the corner, but let's still welcome our last speaker before lunch, Dr. Mohamed Yacoub Janabi, who's WHO's Regional Director for Africa. Let's please welcome Dr. Janabi, and thank you very much to you all for your patience.
Thank you, Madam Moderator. I think this is the best time to present when everyone is hypoglycemic. Huh? So, honorable ministers, distinguished leaders, colleagues, my brothers and sisters, we've been here since morning. We've heard everything. I think we meet at the moment when choices really matter. From Abuja to Lusaka to the Accra reset, we've agreed on what must change. We know the systems we need. We know the inequities we must end. What we have learned through HIV, Ebola, and COVID-19, it's simple. Delay has a human cost. Inaction has an economic price. This is what we've been hearing here the whole morning. So the question before us is no longer why we should invest in health. The question has been answered by loss of lives, loss of growth. The real question is this: how do we turn these urgent health needs into reforms that institutions can trust and finance? That's the main question. Because let us be very honest, since morning here, money does not flow to intentions. It flows to credibility. And as an African proverb reminds us, by coming and going, a bird weaves its nest. Credibility is not declared. It is built step by step, decision by decision, through clarity, discipline, and delivery. So what turns a health priority into something financeable? First, I believe strongly, is clarity. Not a slogan, not a promise, but a defined intervention with really beneficiary, a really timeline, and a really cost. What exactly will be delivered, for whom and when? When priorities are vague, confidence disappears. When they're clear and costed, capital always engages. And what we must say this plainly, we heard in the morning here, health is not consumption, it's production by itself. So healthy people work, learn, and build economies. Every dollar we fail to invest in health today returns as a much higher bill tomorrow. Paid in crisis, last year in Africa, we recorded WHO 114 crises. Lost productivity in emergency spending. The second thing is sequencing. Reform is not everything, everywhere, all at once. It is a disciplined progress. What can be delivered now, what must follow, and what can the system realistically observe? Sequencing is not a technical term. To me, to us, it's leadership. The third thing, and this is a decisive reform, is reform linkage. Health priorities cannot live outside the government systems. They must be costed, budgeted, and owned by us. Is it in the budget? Does the Ministry of Finance stand with the Ministry of Health? A priority with no budget line and no accountability must inspire applause, but it will not unlock financing. This is why today's session since morning really matters a lot. First, anchors health in a credible physical frameworks, then choose the right financing instruments, and finally, matches those instruments to country reality, not aspiration. What requires grants, what can take concessional lending, and where does blended finance work and where it doesn't. So using the wrong instrument is not ambition. We heard in the morning, it's the West. So friends, the matching exercise that follows will succeed only if financing lands in a functioning reform process. Africa is making a necessary shift from treating health as a cost to financing it as a core investment in stability, growth, and dignity. Let me end simply, if we want trust, we must bring something solid, a clear, costed, sequenced plan embedded in public financial systems, owned by finance and health together, and monitored for delivery. Because the currency of financing is not ambitions. I repeat, it's credibility. So let's build this together. And I'll finish just with one comment. I've heard it over and over here again, and it's something which sometimes makes me nervous. I support it, is on local production. or local manufacturing. It needs planning. If we don't plan, one day the 54 member states will wake up and we are all of us producing paracetamol. Who is going to buy it? So really, my sincere request to all the financiers, member states, ministers, and we organization, we really need to sit down and plan. Who produces what? AMA here has got 24 drugs, and AMA and NEOPAD, they've got 24 drugs. We really need to sit down and plan whether we are going to use regional economic communities, we are going to use ECOWAS, East Africa, SADC, Sahel, SAMEC, whichever, but we need planning. What do we want to produce? Who should produce what? And at the same time, look on our maturity regulatory system, because we have only, collectively, I think we have only 9 countries in Africa which have got maturity level 3. Let me finish here by wishing you bon appetit, and our discussion will continue. I thank you very much.
Recording stopped.
Oh, ladies and gentlemen, you'll be very happy that we have unlocked the fasting option of our conference. I'm not going to stand anymore between you and your glucose level. Of course, it's time for lunch now. Enjoy your lunch. So for those of you who have been invited to the Ministerial roundtable, please follow our protocol team. They'll take you to the venue. And for the rest of us, lunch is served in the restaurant. I just want to tell you that there is a knowledge fair. Did you know about that? It's fantastic. I encourage you all to grab some lunch, then pop around the coffee area where you'll be able to find out about innovation and a lot of success stories. So we break out for 1 hour. Bon appétit and see you later. Hello everyone, welcome back. Rebonjour à tous. J'espère que vous avez apprécié le déjeuner and that you are feeling refreshed. I just have a quick announcement before we resume our program. I'm calling all ministers who are going to the side events at Idu Matalaba to please now proceed to the exit and make your way to this venue. So I'm calling all ministers who are attending the side events at Hotel Idu Malabata. Let me just remind you of the theme. It's domestic resource mobilization, a key lever for Africa's development. Please make your way to the hotel now. Thank you very much. And we'll be resuming our program very shortly. Excellencies, ladies and gentlemen, let's go back to work. I can see the smiles are back after a nice lunch, I hope. So we've been discussing the capital here, the how much and the where from. Now let's shift to the machinery that makes the capital work. The reality is very simple. Health financing only scales when it's credible, and credibility requires data, of course. Digital governance is not a technical footnote. It is the confidence architecture that makes our financing trustworthy to investors, verifiable to finance ministers, and accountable, of course, to citizens. Without it, I like to say that promises just remain promises. So we're going to dig into that right now. And let me call our next speaker to talk about it and set the scene. So please welcome back on stage the Director General of Africa CDC, His Excellency Dr. Jean Kaseya.
Excellencies, dear colleagues, I think you had the opportunity to enjoy your lunch and you will not sleep because you took time to digest. We are talking about a theme that is so critical for us in Africa. As you know, the AU Assembly approved what we call Africa Helps Security and Sovereignty. This is now our vision in Africa with 5 pillars. One of the pillars is health financing. We discussed that a lot. But we also have digital transformation and AI. Those who are in the area of public health, they know in the past we are talking about new public health order. What is the difference between new public health order and the AHSS? It's just because we didn't consider digital transformation at that time. Why it's so critical? And why did we go to the AU Assembly to say we need an African champion for digital transformation and AI? As you know, the Prime Minister of Ethiopia, His Excellency Abiy Ahmed, was approved by all African heads of state to become champion for digital transformation and AI. But you know, we need to convince our leaders for them to approve. What are evidences I have to provide? I said, look, let us talk about money. Let us talk about fact. We are talking about 40% of inefficiencies. We are losing 40% of our health financing due to inefficiencies. That money can help. I also told them, without the digital system, we cannot reduce the ghost workers issue. As I shared with you this morning, a country like DRC, Nigeria, and others, they are struggling with the ghost workers issue. You cannot address that without a strong digital system. I also shared with them that we are losing more than 30% of our health funds due to procurement issue. The overpricing, as we saw in Botswana, when the president declared the state of emergency, that one cannot be resolved if we don't have a strong e-procurement platform. Then my leaders, they say, DG, you are talking about digital governance. What do you really think we need to get from that? In addition to funds that you are talking about. I say, Excellencies, you'll be reducing the fragmentation that you have in your system. You'll be putting in place a mechanism that will help you to improve the budget execution, and you'll bring trust in your system. Why today are we discussing this topic, in addition to what I shared with you? Why this one is closely linked to the health financing. We discussed the issue of out-of-pocket. Most of you, you know that there are some countries in Africa where out-of-pocket represent more than 70% of the health financing mechanism. It means poor people are paying to become again poor. It means the government is not investing more. And if you see the remaining part, we are talking about external support. Now that there is headcut, this external support that was supporting critical areas is now under the burden of poor people. We said digital system will reduce out-of-pocket if we manage to put in place a payment system that is electronic, because that one will avoid leakage of resources. That one will also help people to know that they can trust the system. I know a country where most 88% of workers are from informal sector. And they are telling me when they are collecting taxes is for less than 10% of the population. And these people are not also entitled to health insurance scheme. Why? Because they still have a manual system to manage the health system, but even the tax system. This is why when you talk to pharma companies, they are telling you there is no market in Africa. I was shocked the first time a CEO of a pharma company told me that. Today, Africa is changing. We understood that we need to support a strong digital transformation agenda. And what are we doing concretely? We are saying digital transformation is a financial sovereignty. It's financial sovereignty because without governance, health data is fragmented. It's controlled externally, and it's underutilized for decision-making process. when the USAID stopped funding to African countries, people, they are just talking about money. But what was critical, even what made us worried, it was also the same day a country like Kenya woke up and discovered that data were gone. We don't want to see that again in Africa. We want now, with a strong digital governance, to ensure that we are honing our data. We are working with Susan Buffett. We are working with a number of partners to put in place the National Data Center, to put in place a network starting from community focus to national level and reaching the continental level to hone our data. This is so critical because without that, those who are requesting data sharing from US, Europe, Asia, and others, they would not come to us to request permission. They know how they will get this data. We want them to come to respect us. Then we need first to control our data. We are also saying we will not dream. There is no digital transformation agenda without connectivity. All of us, we know that in 2024, only 36 Africans were connected to internet. How can you conduct a strong digital agenda without connectivity? We decided for where it is possible to support countries to get digital connectivity platform. Some of them, like LinkedIn and others, will help us to decentralize the digital agenda by providing connectivity and allowing digital payment, insurance enrollment, and financial tracking. We are really moving, and we want to hear from you today, colleagues. What are your experiences? What can we do together to make sure that me, born in a country without landline at that moment, the first time I used the phone, it was not a landline, it was a mobile phone. It means Africa today can also jump steps to be at some level. In my country, if you go even in a village, people are using 4G, but they didn't know what was a landline. Colleagues, want to hear from you how Africa can accelerate this agenda to make the health security agenda, but also the health sovereignty agenda moving. With that, I will be so glad to hear from you, like all other colleagues, to learn from you, and together we can see how to make this continent moving. Thank you so much.
Thank you, Excellency. And now to dive into the power of data itself and how we harness frontier technologies for economic transformation, let's now welcome the Chief of Emerging and Frontier Technologies and Digital Transformation at the ECA, Maktar Sek.
Good afternoon, bonjour. Let's wait if we get the demo online. But while waiting this screen, let me start saying something on how technology is very important on digital in health sector. We can remind three things, three takeaways on technology in digital health. First, connectivity is a foundation of digital health. But second, connectivity and technology are not enough. We need to have this quality of service to improve in the continent. The third, we have a deficit on technical capacity on digital health. We need to build our skills on digital health. Please, I need the live demo, please, not the presentation. Please go to the website, the online presentation. First, why we have this, we developed this digital twin platform. It is a simulator. Now, please go to the website. Please, the link on the website. Because we don't have enough time to go through the presentation, I want to show you quickly the several functionality of this simulator. Merci, the link is in the email. Yeah, let me go there. We are coming now. Hello. The micro, let me use this micro. I will go into too quickly here. I'm going to be fast. Let me switch in French to be fast. Pourquoi on a cet outil de simulation pour le secteur de la santé? C'est un outil d'abord pour permettre aux utilisateurs d'analyser les données fiscales et les décisions financières ainsi que les chocs externes pour voir comment cela peut impacter le secteur de la santé. Quand on parle d'impact du secteur de la santé, c'est en matière d'investissement, de couverture aussi et de résilience du secteur de la santé. C'est un outil qui est destiné à qui? D'abord, au ministère des Finances, chargé des Finances et Planning, pour avoir une meilleure planification des dépenses à faire dans le secteur de la santé, voir comment on peut jouer sur l'impact de la santé sur le PIB et leur part aussi sur le PIB, et voir aussi comment augmenter la couverture sanitaire à travers leur pays. Donc ça, c'est pour le ministère de la Santé et comment aussi optimiser les dépenses de santé. Pour le secteur de la santé, ça permet aussi de voir comment on peut améliorer la santé au niveau, la couverture sanitaire au niveau et la résilience au niveau de leur pays. Et ça leur permet aussi de mieux avoir un planning, surtout au niveau des vaccinations, des campagnes de vaccination, et aussi quand il y a des épidémies. On avait développé une plateforme similaire quand on avait la COVID-19 pour l'Afrique. L'autre point important, c'est pour les partenaires, parce qu'on va voir comment on peut simuler, affecter une partie de la dette aux dépenses de la santé et comment ça peut impliquer aussi le secteur sanitaire. Et pour des organisations internationales comme l'Union africaine, la CIA, les régionales communautés économiques, aussi c'est un outil qui leur permet de faire des analyses et des comparaisons, des analyses aussi financières sur les dépenses de santé et les politiques sanitaires au niveau de l'Afrique. Le simulateur est basé, let's go down please, down, no up, up. Donc on a dashboard, allez-y au dashboard. Donc, go down please. Donc, le simulateur couvre presque l'ensemble des pays africains. Donc, au niveau du dashboard, du tableau de bord, vous avez les dépenses en santé calculées en fonction du PIB. Aussi, les dépenses de santé pourcentage par le pays. Et aussi, les dépenses de santé par personne. Comme dit, $86, c'est ce que le gouvernement paye pour les personnes. Et le taux de couverture sanitaire qui est extrêmement important. Le budget total. Et au niveau du service de la dette, quelle est la part qui peut être affectée pour financer le secteur sanitaire et la dépendance aux donneurs et aussi la résilience du secteur de la santé. Ça, c'est des éléments qui existent au niveau de l'ensemble des ministères de la Santé. Maintenant, l'objectif, c'est de faire une simulation. Quel est l'outil? Qu'est-ce que ça nous donne? D'abord, si on clique sur Simulation Lab, please click on. Donc, pour un pays comme le Kenya, on a plusieurs scénarios. Donc, on peut jouer sur le pourcentage de la dette qui est affecté au secteur de la santé. Ça, on peut modifier, on peut mettre 3%, 2%, 1%, 0%. On peut aussi stimuler comme paramètre sur le taux de vaccination, si on booste le taux de vaccination, comme c'était le cas du COVID. Aussi, sur le manpower, le nombre d'emplois dans le secteur. Aussi, on peut jouer sur l'inflation. Donc, tout ça, c'est des paramètres qui sont à notre disposition. Et ça dépend maintenant de la politique nationale qui est menée au pays en fonction de leur plan national de développement, sur quel levier le gouvernement pourra appuyer pour impacter le secteur de la santé. Par exemple, si on prend ces données, ces paramètres, affecter 3% de la dette au secteur de la santé, on fait la simulation pour voir. Run simulation. Go down. Donc, on voit qu'il y a la couverture qui augmente, la résilience, le budget et le debt service. Go down, on va avoir les informations. Donc, on a vu qu'avec cette simulation, le taux de couverture est passé de 57,8% à 66%. La résiliation aussi est devenue beaucoup plus consistante. Mais on dépend toujours des donneurs parce qu'on a pris une partie de la dette, on l'a affectée au secteur sanitaire. Et on voit que le gouvernement met plus d'argent sur les dépenses sanitaires par personne, mais aussi le budget a une légère augmentation. Maintenant, on peut sauver le rapport, save the report, et go to PDF. Et là, on a le rapport de cette simulation. Donc, on voit que la couverture a augmenté de 2,8%. La résilience aussi. Plus important aussi, c'est out of pocket share. C'est ce que les personnes dépensent pour leur santé. Ça a diminué de 2 points. Donc, on dépense moins. Le citoyen dépense moins avec ça. Et l'impact sur le GDP est de 4,4%. Et ce fichier, on peut l'imprimer, on peut le sauvegarder et puis continuer à faire des analyses. De la même chose, on a beaucoup d'informations, beaucoup de données concernant le pays. Tout ça, c'est généré au niveau de la plateforme. Go back. Donc, c'est un outil très puissant que chaque pays peut tester parce que ça ne demande pas beaucoup de données au début, mais il y a beaucoup de paramètres qui sont aussi mis à la disposition, de données qui sont mis à la disposition du pays. Donc, pour conclure rapidement, pourquoi cet outil est important? D'abord, c'est un outil qui nous donne des éléments en temps réel, des analyses en temps réel. Et chaque pays peut l'utiliser. C'est un système ouvert qui ne demande pas de la licence et la CIA peut mettre ça à disposition à l'ensemble des pays. Il est conçu pour respecter tout ce qui concerne les politiques sanitaires définies au niveau des États membres et aussi au niveau de l'Union africaine. Et cela aussi va permettre d'améliorer la situation sanitaire au niveau de l'ensemble des pays du continent. Et the system will show also the importance of digital technology, of using technology in health sector. I think we discussed a lot this morning, since yesterday, the role of digital technology in the health sector. You have it in the economic report for Africa. Also this morning, there are a lot of discussion about that. And this tools, it is a good means for African country to overcome to the issue they are facing in the health sector. Thank you.
Merci beaucoup, Monsieur Seck. Vous nous avez plongé au cœur de cet incroyable outil. C'est vraiment un exemple parfait de la technologie au service de la santé. Merci beaucoup. So now let's dive into one of the most important issue, which is accountability. So please, let's all welcome Dr. Michel Sidibé, the African Union Special Envoy for the African Medicines Agency. Welcome.
Thank you very much.
Thank you very much.
I don't know if I have to say good afternoon or whatever greetings I need to use because now the only thing I am missing is food. Not of food for thought, but of real food. I did facilitate without eating, but thank you very much. I think this subject is timely and is topical, and I found the two presentations very well done. The first one from my young brother, Jean Cassia from CDC, and the presentation now, which is showing us really that we can produce a tool which will be helpful for transforming and monitoring whatever we are doing. So, Excellencies, you know, what you have just seen changes the way we govern health financing. It is not just a dashboard, and I can insist on that. It is a digital accountability instrument. Let me start with a simple truth, which is important for me. At the center of health financing today, we heard it this morning, is one fundamental issue: truth. I think the only one fundamental issue is trust. And trust between government and citizen, trust between ministries, trust between countries and their partners. And that trust depends on one single thing, accountability. Because health financing is not only a technical issue, it is a question of accountability. Accountability for results, accountability for right decisions, accountability for every dollar invested. We are entering a new era of health financing, an era of constraint, fragmentation, repositioning. Development assistance is plateauing. Global solidarity is becoming more transactional, and major partners, including United States, are shifting towards bilateral interest-driven approaches. This is a structural shift, and it is changes which is bringing at the center the question which is fundamental for all of us: how do we mobilize more resources? How do we build the trust by ensuring that every resource delivers results? Because what Africa needs now is not only more financing, it needs credibility, transparency, accountability. In today's reality, donors expect results. Ministers of finance expect returns. Citizens expect fairness. All are asking for the same thing: trust, built through transparency and accountability. This is where data, digital tools, and increasingly artificial intelligence become essential. Data creates visibility. Digital tools enables better decisions. Artificial intelligence strengthens prediction and precisions, but accountability is what builds trust. Because technology alone is not enough. Technology is the enabler. Accountability is the driver. Trust is the outcome. We are moving into, like I said, a new era. Precision, public health, and precision accountability. This is exactly what this instrument enables. A fiscal health simulator, a tool to track expenditures in real time, model decisions before committing resources, identify equity gaps with precision. And this is where transformation happens. It shifts us from expenditure to performance, from inputs to results, from opacity to accountability, because this is ultimately about power. The power to decide, the power to prioritize, and the power to be held responsible. And when accountability is real, trust is rebuilt, domestic financing strengthens, partnership become strategic, not dependent. So the question before us is simple. Are we ready to build trust?
by being accountable for the result we have been promising, because in this new reality, accountability, like I said, builds trust, and trust is the foundation of a sovereignty. Thank you very much.
Merci beaucoup, Dr. Sidibé. Merci. Let's now move to our panel discussion and to hear from the people building and deploying these systems, and also from the countries and institutions putting them to work. So it's my pleasure now to call our moderator for this discussion, Pradeep Kakatiya, co-founder of the Health Innovation Exchange. Welcome, Pradeep. I'm also calling our panelists, Mrs. Njeri Jomo, Chief Executive Officer and Principal Officer at Jubilee Health Insurance. Professor Nikes Ndembi, Deputy Director General and Regional Director at the Africa Regional Office of the International Vaccine Institute. Let's also welcome Dr. Majda Robalo, President and co-founder of the Institute for Global Health and Development. Dr. Karim Bendaou, Africa Engagement Committee Chair, International Federation of Pharmaceutical Manufacturers and Associations. Let's also welcome Dr. Veronica Jambi-Kihugi of the Health Systems Insights. Dr. Leopold Zekeng, Head of Developing Markets, Biotechnologies, and former UNAIDS Country Director for Nigeria. And last but certainly not least, Dr. Ifedayo Morayo Adetifa, Chief Executive Officer at FIND. Welcome to you all, Pradeep. All yours.
Thank you. Thank you, Anne-Marie. I'm going to stand for the simple reason, for those of you who haven't noticed yet, the microphones are on the right of the speaker, and every time they turn to the moderator, I just couldn't hear anything. So is it okay if I stand? Yes. Okay, I want to hear you better. And also, one other thing that you need to know about me, when I'm walking towards you, if you're speaking too long, I'm coming to actually stop you. Sometimes I have to, sometimes I could do that. But thank you very much. I think this is a conversation all morning. I was absolutely fascinated by the number of people who stayed, left their lunch behind and stayed on. So first, I want to say thank you to all of you who braved it and stayed here. I don't want to take too much time in providing an introduction, because the introduction that's been provided by Dr. Kasaya, by Michelle, and the wonderful presentation by my neighbor, Sek. It looks like we have the understanding of the challenges. We have a very clear understanding of the financing. We have plenty of tools that have been presented today. And yet, 150 million people fall into extreme poverty every year. Why are things not working? And I'm going to put my wonderful former colleague from the UN, Dr. Magda Robalo. You have been a minister in the past, you have worked with the UN, you provide the thought leadership on so many different areas. Is it a challenge with financing? Is it a challenge with governance? Is it a challenge with leadership? What will it take for us to find a way to scale access to healthcare and the investment that is needed behind it?
Thank you. Thank you very much for that question. And it's a good opportunity and a pleasure to be here. I would say it is a challenge with governance, and it is a challenge with the mindset. Mindsets about the way we look at health. As a system, interventions, technology, medicines, vaccines, rather than a broader well-being, depending on the kind of housing you live in, how much closer you are to have, for example, access to internet and all the goodies that we don't think immediately that they are connected to good health. During lunch, we heard that the export of health workers from the continent, the exodus of health workers to greener pasture. For example, someone was mentioning that the British health system has 80,000 plus foreign health workers. And we are complaining that we are training people and they are leaving the continent and they are leaving our health systems. It is because they don't have conditions to stay. So health is also about giving health workers and the population in general the conditions to stay. And this is governance. Good governance is the only way for us to get better health outcomes. As long as we continue to look into health solely as being a product or an outcome of availability of medicines, vaccines, technologies, etc., we will fall short of doing a good job. We need good governance. The rule of law matters. Accountability is important. Inclusive participation is important. There are articles that can be referenced. Countries with good governance, with good democratic systems, with the respect for the rule of law, have better health metrics. I don't understand why do we need to mediate the conversation between ministries of health and ministries of finance, bring them outside their own countries to make them understand that it's important to invest in health for the economy to grow, for the fiscal spaces to be broader, and then we get better societies. For example, that's the problem if you look at it. Why is it that ministries of health, I have been Minister of Health and I know that often the Gavis and the global funds of this world need to be in country for us to discuss some more specific issues that otherwise would have not been discussed. And I know it happens in many other countries because I've worked also on during my time at the UN. So if we start from good governance, which is not easy to touch, but it's important, we will improve health outcomes. Mindset shifting is important. Health is immaterial, and it's not always understood as something that is an economic value. And we need to start thinking differently. I'll stop here for now. Thank you.
Thank you. I love the mindset point. I'm going to turn to the audience. How many of you believe that there are two standards when it comes to access to healthcare here? How many of you believe that our leaders travel to London, Paris, or elsewhere for healthcare, whereas the ordinary person has to stay locally? So it doesn't really matter what the quality of healthcare is. Okay, I have a lot of people who don't think that is an issue. Okay, so we need to, if you don't feel the pain, you don't understand the problem, right? So maybe that is something, again, coming back to mindset, I'm trying to see if that's also something which we need to really educate internally. Thank you so much, Magda. Maybe if I can go to Njeri. Njeri Jomo is the CEO of Jubilee Health Insurance. Njeri, tell me a little bit more about, again, going back to the 150 million people who go into extreme poverty. For me, that's a market. That's a huge market because they're spending out of pocket, and that is an opportunity for insurance. Yet about a quarter of the people have access to insurance here, health insurance. Where do you see this market going? What is preventing larger engagement in terms of private health insurance? What are the impediments? What are the changes that you would ask if the ministers of finance were sitting here and the people who make policy are sitting here? And you may want to introduce yourself also. I've done a terrible job of introducing the panelists, but I'm always thinking that everybody knows you. Otherwise, you can Google them, but please do introduce yourself briefly.
All right, thank you. So my name is Jerry Jomo, as introduced. I'm the CEO of Jubilee Health Insurance. That is the largest insurer or health insurer within East Africa. We are part of the Aga Khan Development Network, and there's quite a bit of investments within our region that span into healthcare, down to hospitals, to schools and so on, really focusing on the issue of healthcare. More recently, we have set up a factory, back to the conversation on manufacturing of medication and drugs, and that is what we do. But back to your question, and if you speak to all those people who end up with catastrophic health expenditure and then have to go out of pocket, if you look at it, perhaps the question is there demand for insurance, or is it demand for health financing specifically? Because what they need is at the point of care. They do want to be able to pay for it. And therefore that begins to be where the disconnect begins. If you look at the person who today pays out of pocket, you think about the fact that they do not, one, prepay for care. And there's a big conversation whether culturally within our regions, our people are willing to prepay for care, or they want to utilize it at the point where they need it. And this is something we see quite often, where at the point where someone gets diagnosed with a chronic illness, that is when they ask, what insurance can I purchase and can it be utilized for this? So I think that begins to be one of the areas where we see a mismatch. The other area is around affordability. And I'd like to attach this as the issue of cost is driven by two issues. One of those is leakage, and the other is structural cost drivers. If you go down to the issue of leakage, today, intended or otherwise, we estimate about 20 to 30% of the claims we receive are fraud, waste, and abuse. Now think about it, that is significant because it has quite an impact on what this person will continue to pay. And when you go back to the fact that what they're looking for is to finance, they're not really looking for it to prepay, then the cost becomes prohibitive. But when we go back to what are the structural cost drivers, you look at the fact that we import over 70% of our medical inputs, and I think that has been spoken to quite extensively. You look at the fact that, for example, one of the practices we see in most of our regions, we prescribe brands. And about 40% of the claims we typically receive are drugs. So you're telling this client who is unwell, or this patient who's unwell, that you're feeling unwell, this is a brand I'm prescribing. And there are many conversations we can have. Back to your question on policy, is if affordability is an issue, should we be prescribing brands or should we be prescribing the formulary? So that then the question becomes, this person is able to purchase or is able to have a drug that is not really breaking the bank on their end and is able to actually get them treated. I think for me, those are some of the issues. And like say, a third one is around the issue of trust. As insurers today, we do not spring up as the automatic option. And perhaps we see there's a symmetry to how well people, a culture, or rather a people understand, have a strong savings culture, and therefore how they then understand the need for protection. If you're still discussing someone who's at the bottom of the pyramid, they're still struggling to make ends meet, insurance is not often the one thing that they think about. So I think there are quite a number of areas there that we see as challenges, and which then causes us to ask, as has been asked a lot today, our view is insurance, or health insurance for that matter, is both a public and private good. And what the government does is provide a social layer. And when you look at what happens specifically for our market, and coming back to Kenya, one of the alternatives that people have chosen to insurance is what we call harambes, or contribution groups. So every other Kenyan will tell you they're in a WhatsApp group where they're contributing and they're raising funds. That, in whatever sense, is some form of insurance. And that makes sense to them because it comes in at the point of need. It speaks to their point of culture, of a sense of belonging. So for us, there's still quite a lot of work to be done. And therefore, if you think about it, is the question that there's a high demand for insurance, or is the question that they need financing that responds to their need? I think it's the latter.
Very interesting. I'm going to pick up 2 points from what you said, and I'm going to put Karim, you in trouble in a minute, so let me warn you already. When you say that the prescription is for branded, is that for branded drugs?
Yes.
Is that because of pressure from the pharmaceutical companies? You can take the Fourth Amendment if you want, but...
I'd be happy to take that, but I'm sure, of course, I mean, today, and I think there's great examples like in India, where you do not, as a matter of policy, you do not prescribe the brand. You prescribe the formulary, and the person is able to purchase what fits within them. But I'd be glad to hear from Karim whether it really comes down to pharmaceutical pressure.
The second one, I'll come back to you, but what I would love to see is, and I know that Abu is someone who's tasked me with, I want practical stuff to come out of this conversation. I'm going to ask you whether it is possible for us to take a couple of countries where there may be an opportunity to look at public-private partnership and look at insurance as a model, but I'll come back to that. Karim, I wasn't planning on doing this, but this was very interesting. This is I mean, given the population size of this continent, it's a huge market. I know that there are challenges. I know that there is the AMA, which is looking at bringing together some common regulatory frameworks. How do we really leverage this as an opportunity rather than as a problem in terms of local manufacturing of drugs? What will it take? What is it that you representing the pharmaceutical industry and association of the manufacturers, is it about 70 to 80% of the drugs that are used is imported in Africa? So I'm just trying to see, how can the industry and the governments partner? How can we have a continental local production that really responds to the needs?
In fact, it's not really a challenging question. It's a very good question. I think it makes a lot of sense to have local manufacturing and to partner with local entrepreneurs. And we have several talents available in Africa who can really build strong and solid pharmaceutical industry and becoming the pharmaceutical establishment of Africa. The issue that they have is a financing issue. They cannot raise money, they cannot raise funds. And at the end of the day, they don't even need the what we call the innovation-based industry. I mean, they can do it by themselves. For generic products is so easy, and we have African talents who can do it. This is one. Let's take it for it. Now, the solution to raise money, you have several solutions. I've been working on one of them when I realized that local manufacturing is directly and this sovereignty, which doesn't exist. And because if you're local manufacturer, do you manufacture API? No. The day you have a pandemic, you can be sure that you will see exacerbation of nationalism. And the API will be under a kind of export ban to those countries. So this is also another issue. But still, it's very important. It's really important to have those people, those talent, being able to raise money and to start to produce locally. Personally, you know, I'm serving a science and technology company. I don't have any issue to transfer any technology, and you can take me accountable for that. Anytime you can call me, you can reach me out to transfer any vaccine manufacturing, any biologic manufacturing process. This is not something which is also that we would like to keep with us. But it's also, somehow we can understand that we cannot invest in 55 countries. I've been a long time ago, like 10 years ago, running the operation for this company in Africa and being the president for Africa operations. It was not easy for me, you know, to, look, I'll just give you an example about the fragmentation that you have mentioned. Today, we are producing a compound and a drug in 6 countries of Africa. And suddenly another one, I will not mention it, said, I will organize an import ban on your product. I said, why?
He said, because you have to produce in my country your product. I said, but it's already produced in Africa. I cannot produce in 54 countries. This is absolutely impossible. So why don't you source it from one of the African country, which is already producing this? So these are the real practical issues that the private sector can face. But I don't think that it is really, I don't see any pushback in terms of local manufacturing. But believe me or not, it should be an African entrepreneur that we can support in terms of de-risking his fundraising. That's a very, and we have to do it today, yeah? And to speed up the process. I mean, out of maybe 5,000 factories that we will have tomorrow, 2,000 will collapse or will go for bankruptcy. We don't care. If 3,000 survive and serve the African continent, that's an achievement.
Thank you. Financing, risk tolerance, and I understand that the ability to transfer technology is not the biggest issue. We'll come back to you on that. But maybe just one quick thing. From your perspective, do you see, and one of the things that Dr. Janabi raised earlier was about we shouldn't be distributing, everybody shouldn't be making paracetamol. So what is that kind of balance that you see happening? Is that happening? Are there countries that we should be, as part of the initiative that Abu is taking, are there countries where you see that we are much more prepared than the others?
I mean, look, first of all, WHO have done part of the job in selecting those countries. This is a maturity level 3 in terms of regulatory environment. So if you have already this ML3, which is reached in a country, it means that this country achieve already high standards in terms of QA, quality assurance, and quality in general, and also in terms of processes and transparency. So today it's very easy to select a country, and I'm really surprised, and I'm mentioning this in this part of the world, but I'm surprised that the countries where the local manufacturing is developed, they are maturity level 2. They are not still maturity level 3. So that's a very, very strange. But in terms to quickly answer your question, yeah, we started to have a kind of indicators which allow us to tell, this country is good, this country is still in progress and doing progress. But I have a question for you. I said, no, guys, you say vaccine manufacturing, we cannot produce everywhere, okay? You cannot produce in 55 countries. And my dear friend here, the DG of the Africa CDC will tell me, yes, let's produce in 5 countries. How are you going to select those 5 countries? Because of economy of scale.
It's a great question. And I know the person who has the answer to that. If you turn to your left and look at Professor Nikes Ndembi, I don't have to ask you the question is already asked of you. But also, I mean, it's like very strange when I see the market, which is there, and we produce, what, 1% of the total vaccines here? What can you do? And to answer the question that Karim has already asked you.
No, I think first, there have been significant progress on the continent with respect to vaccine manufacturing and other medical countermeasures. So where we left during COVID, I think Africa CDC just wanted to be sure we put that in our record, is that a lot has been done in terms of mapping, gap assessment. And currently, I think we have close to 25 really active vaccine manufacturers on the continent. We talked about the instrument this morning, AVMA. We talked about other enablers, but I want to really come back to the enablers that were identified when the framework for action was developed for local manufacture on the continent.
There were 8 bold programs identified. So you have the market shaping. That's why the agenda on pool procurement is extremely important in what we're doing. Research and development, regulatory systems, human capital development, IP and tech transfer, infrastructure and coordination by institutions leading this initiative like the Africa CDC and other agencies. Very important that we acknowledge some of those enablers. So when we move from there, it's important as well that there's an enabling environment for those manufacturers to be able to actually get access to the global market. So that's a very critical step. We have a very good example from South Africa where local manufacturers competing with multinationals, they were not able to get through. We really want to be sure we established on this continent platform to be able to get those products out. I think this is important. By 2030, I think the data from the Africa CDC is very clear. We have 8 products that are going to be on the market. So I think that's where the preparation on this APPM is extremely, I keep it saying that, critical for the industry across the continent. That's going to apply to the diagnostics, therapeutics, more so for vaccines. So that's why this call probably with the international, what you're doing is very important also in really plugging into what the continent is really aspiring to. 60% by 2040. I think this is very ambitious. It means that requires really strong partnerships and be sure that we really tap into the right resources. Maybe we're going to come into the financial or innovative financing to see how these manufacturers can actually benefit and be competitive on the market. Thank you.
Go ahead.
No, thank you. My question about where do you set this manufacturing facilities was related to, let's say, let's take a country, Egypt, 100 million inhabitants. You have a vaccine. The day you have a pandemic, do you think that they will start to serve themselves or the entire continent? So my recommendation always is to go for tiny and small country in terms of population, where you set, because they will never be able to organize an export ban on 200 million doses. There will be 10 million inhabitants or 12 million. So that's maybe the idea, but I don't know. That's a strategic decisions and political one as well. So
I think Michel is the one who said that solidarity is dead, but maybe, I don't know. But also maybe if I can come back to you, you are basically incentivizing vaccine manufacturing. I remember yesterday you were convincing Michel that for every $1 that the country invests, you provide $5. Tell me more about that.
No, I think the question is, how do we really engage meaningfully our leaders? Because we need scientific leadership, political leadership, and ownership on this local manufacturing agenda as a continent. We will be able to do that if we have a very clear message to our leaders. They want to see the return on investment. If you put in $5 million into the business of local manufacturing, what do you get out of it? There are some quantifiable measurement and unquantifiable measurement as well. Health security, there's no price for that. How would you quantify it, even on the return investment model? It's going to be complex. So the lessons we have learned from COVID, we need to be prepared. And this is a continent of 1.5 billion people. And so far, I think we probably won vaccines that we all know, the yellow fever vaccines. If COVID strike now or any new pandemic, I think we are better prepared. You know exactly what happened with Afrigen Biologics in South Africa, at least mimicking the mRNA technology. Back to your question. The return on investment calculation is quite complex. It's going to be based on infrastructure. It's going to be based on the demand. It's going to be based again on what we're actually seeing the projection for the next coming years. So what you're trying to allude to is the Achieve Africa, where we're actually really encouraging our government to invest into research and development. Currently, we spend less than 1% of our GDP in R&D. You cannot be aspiring to manufacture 60% of the vaccine by 2040 when we spend less than 1% of GDP onto R&D, science, innovation, and technology. That's a strong call. So what we're saying, we need to stop that model of dependency, start investing into R&D, encouraging our member states to put in little resources in, and then probably matching what donors are putting in and partners to be able to drive that agenda. So it's quite broad to be sure that $1 can actually, I mean, it's more than even 5. I think based on the conversation we had with Dr. Michel Sidibe on this, I think it's even more than that if you look into. So we have data from Ethiopia suggesting that a $5 million can actually bring $30 million return to the country. So that's based on that assumption. Thank you.
Brilliant. Then if we look at the early adopter countries, if a country comes and tells you we can put in 10 million, you're basically saying that there will be at least 50 million in returns.
More than that.
More than that. Yes. Brilliant. We'll hold you to that.
Yeah.
I think if we look at the whole vaccines, we are producing less than 1%. Drugs, it's about 20% is locally manufactured. And then Dio, I'm looking at you, almost 0% of the diagnostics is manufactured in Africa on the continent. FIND has been a leader in bringing new technologies, enabling that access. What is your advice? What's your plan for Africa? How can we really be, because diagnostics is the ultimate truth. The kind of accountability that was presented here, the need for it, the trust, it's in your hands. What do you recommend?
Well, thank you. So we of course, we're at a health financing meeting. We've had lots of conversations or sessions about health financing, and borrowing from Big Brother Michel, let me be provocative now and ask if the problem, for health financing, is the problem money, the availability of money, or is the problem one of us actually financing health systems that cannot see? Okay, in my view, and of course I come from that work on diagnostics, I think there's data that suggests that almost 1 in every other person, 1 in 2 persons do not have access to diagnostics. And that gap is worse here in Africa, which means we're treating people for conditions that we're not sure they have, or we do not have full knowledge of the health problems that actually affect most of our population. So how do you allocate resources to what you cannot measure? How do you invest in health without investing in diagnostics? I mean, are you likely to build roads without using a map? I mean, the quantity surveyors and the engineers go around for weeks putting strange chalk marks and all sorts of things on the road. So that for me is the issue. And in response to that, I think in the conversations between health and finance, we need to make it very clear to finance ministers and to others who control the purse strings that investing in things like diagnostics as an entry point to healthcare is a structural matter. Okay, so if you spend $1 on a treatment without a confirmed diagnosis, then that dollar is at risk of waste. Okay, so if you have a health system that cannot test, then obviously you cannot detect outbreaks and you cannot respond to outbreaks. Okay, you cannot manage chronic diseases. This is why we've got now an epidemic of chronic kidney disease. We see diabetics when it's time to cut off their feet or when their nerves are no longer working. And we cannot demonstrate, the benefit of improved outcomes or return on investment because we've not invested in diagnostics and properly collected the data that we need to underpin all of those arguments. How do you tell the investors that if you invest $1 million in the diagnostics products, and I'm talking about local entrepreneurs now, not the people with deep pockets. It's very difficult to go borrow money from the bank without being able to give a feedback on when you expect to be in the blue. So Nikas talked about investment in vaccines, but it will be interesting to know that all of the investment in R&D for diagnostics, apart from those that went into COVID, in total was just $13 million in 2023. And to break that down into a way that I think people can understand better, that amount will buy you 100 full option Land Cruisers. And we have that driving around in many capitals, in even the countries that are supposed to be poor. There will be several 2026 full option Land Cruisers on the streets. And yet we do not have the, we're talking about lack of domestic financing and absence of money for that. So I do not think that this is a market failure. I think it's a financing choice that in Africa that we can reverse if we choose to do so. I'll just end by talking about, talking about returns, we already have information or evidence that suggests that if you invested in addressing the diagnostic gaps for 6 priority conditions, you will prevent 1.1 million premature deaths in our parts of the world. We're talking about hypertension, diabetes, HIV and AIDS, malaria, then the sort of hepatitis B and syphilis and co that you have in pregnancy. So 1.1 million premature deaths is not a health statistic, okay? It's a statistic for GDP, for taxpayers, and everything else that countries depend on in estimating sort of what the populations, the healthy populations contribute to the wealth of nations. And I think that if you prioritize diagnostics as you should, and by that you're able to prevent disease progression, you are able to reduce hospitalization, reduce waste, lower catastrophic out-of-pocket spending, and cut the downstream cost because you have kept people healthier for long, then it means, very clearly investing in diagnostics is not just a health issue, but it's actually a matter, it's a cost containment measure for our health budgets. So I'll stop there before you approach me.
I'm wondering how your neighbor looks at risks and pulls those risks without diagnostics, but I'll come to you in a minute. But maybe if I can go to Veronica. Veronica, you're a systems design thinker. You look at health systems. For me, what I still don't understand is where are we failing when it comes to, the data that was shared was 40% of our health products are wasted. Where do you see the challenges? What has been your experience when you look across countries?
Thank you. So I think the key problem that we are all speaking about is having our systems very much opaque. So,
come closer to the microphone. Can you hear?
So most of the data that we have tracks outputs. So we are talking about, we are seeing reduced visits in our facilities. We are seeing less people taking up health insurance. We are seeing less mothers coming for antenatal clinics, but our data rarely looks at the inputs. As the DG said, we are rarely looking at how many staff have been absent this year. Our facilities have equipment. Are those equipment working? How many of those equipments are broken? Are we looking at when our facilities or our health systems are expecting payments from our insurance systems or from government systems, are the payments delayed? So we think facilities have money and they don't. So what we are lacking is a digital governance system that directly links the health data that we are seeing to decision making, to resource allocation, to purchasing decisions, and even to public accountability. So our data systems are there. There are so many of them, but they are fragmented and they lack visibility, clear visibility that we can trust. So that's why we still have a problem. We are still not able to make better decisions.
And what is needed to change that? What will make that availability of data and that intelligence, is it lack of focus on that? Is it lack of investment in it? Is it just that the whole area is fragmented?
So I'll call it performance management. As decision makers and health managers are not doing performance management. Performance management means having real data that tracks health inputs, from health inputs to implementation of these healthcare systems to the outcomes that we are seeing. As well, our managers, when they have the data, they don't have autonomy to make decisions, and nobody holds them accountable. So if I come to your facility, to maybe primary healthcare facilities in many of our countries, and I see that you're now seeing less patients, as a manager, I should be able to ask, why are you seeing less patients? Do you have enough equipment? Are your staff coming to work? And if they're not, am I holding you accountable for this? So if there are medicines, if all your clinicians are prescribing branded medications, but your facility does not have the branded medications, am I holding you accountable for that? And as a health manager, do you have information on this? Are you aware about what is really going on in your health system?
Okay. Your neighbor is someone who is working on the other side, on to your right, actually. He's, Leo, you've worked with the UN and you're now part of a private data company that's really looking at transforming healthcare using AI, looking at digital infrastructure. What will it take? Is AI going to solve our problems? Do you see Africa is ready for leveraging digital? Where do you see the investments needed? Where do you see the fault lines?
Well, thank you, Pradeep. I'm Leo Zeken. As you said, 3 months today, I joined Dure Technology. I left the UN after spending, 20 years. Nigeria was my last duty station. Building on what Veronica said, and starting where the Minister of Health of Ethiopia left today. She said we need better data for better decision and for better health outcomes. And Michelle mentioned data and for accountability. You mentioned results and decision. So the key question for Dure, which we are trying to promote, how do you, in the context where electricity is unreliable, we've heard that from so many presentations, where connectivity is poor, where digital infrastructure is limited. Matasek mentioned from the ECA mentioned the fact that skills and capacities, so digital health are limited. DG ACDC mentioned the fragmentation. The reality is, if you look at our different platforms, they are fragmented. They're operated in silos. What is the result? The result is you don't have good data on time to make sure that you can make decisions. So at Dure, we believe, to your question, what will it take? We believe on an harmonized approach, a unitized approach, where you have a facility at the center and you bring together, and the word together is important. You bring the solutions, you bring the digital infrastructure, and you also bring at the same time the capacity. So your digital solution could range from EHR, it could range from HR and financial management, it could include ELMIs in terms of stock out, you name it. But what I'm just trying to suggest here is that there are solutions which will respond, so to country needs. You can scale them, but what is important is that those solutions are integrated to reduce the level of inefficiency. More so, interoperability, it's important, and it gives you real-time data. To your question, big yes, that you will have to include AI, but maybe AI which is trained, so using our own set of data, not the AI trained elsewhere, so for the purpose of ownership. Yes, the data will come in to give you more analytics, more insight, more prediction, more alerts, so more value for your money. We can spend time on that. The second component, which is important, again, on getting together, it's bringing in, the the infrastructure. Solar, we bring solar. Having solar will do more than just helping the digital transformation units. You will take solar energy, so electricity into the delivery rooms and so on and so forth. Our partnership with Starlink, we will bring the connectivity and also the tool, so I'm talking about the PCs, I'm talking about the laptops and so on and so forth. Last component, it's around capacity building and institutional strengthening, where we train people around and data. Michelle mentioned having the communities involved. You're talking about accountability. You need to bring in also the voices of the right holders. So we have a tool.
Let me ask you one thing.
Yes, please.
Dr. Kaseya said that the data sits somewhere else usually, and when USAID went, all the data went. Where does your data sit?
So thank you so much, Pradeep, from the question. So with the model that we are having, so what is really happening is that at the national level or the regional level, to your question, you can have data warehouses where those data could sit there. Can I continue on the community level, so which will then allow you, so to get the voices of the community in such a way that there's mutual accountability between the duty barriers and then the right holders. So there's a tool also to make sure that it happens. So then you have a full circle in terms of accountability.
Brilliant. I'm told that there is a reception which is to follow, so I don't want to be standing between. Lunch is okay, but if you're standing between wine and people, that's even more difficult. I'm going to really try and push us towards one practical thing that we can take back with us. So for each of us, the question is the same. If Abu brings 3 countries that are early adopters, want to go ahead, are completely interested in this, what is your offering? What's your ask? Let me start with you, Professor.
No, I think it's pretty simple. We have to be practical, as you've said. And then based on the conversation this morning that I was listening carefully, I strongly believe we need a unified, real-time, I say real-time, where we get data. The dashboard was presented here. Unified means that the 55 countries are all tapping into, probably loading their data on that unified platforms.
What do you bring?
What do you mean?
What do you bring to the 3 ministers who are saying, okay, we want to do something? Tell us what can, from a vaccine perspective, what can you offer them?
No, but I mean, if you start first aggregating data at continental level, I can switch to the vaccine side. We can look at the genomics, which is the starting point for manufacturing. If you get the aggregated data from this continent, you can develop immunogens. I think, Karim, you can confirm. For diagnostics, therapeutics, and vaccines. Because we are not working in a very unified way, they are all data sitting across board. And then the issue of data, the genomic data for this continent doesn't sit in Africa, it's somewhere in Los Alamos database in the US. That's an issue. Unifying data for genomics can enable us move this agenda on local manufacturing. That will enable us to provide accountability for those who provide those samples. And that can link you to what we're calling the pathogen access benefit sharing. There's a lot we gain into really working together, unifying data, being sure that we're accountable for our citizens. I will close by saying data is currency. I think it's important that we understand it. Thank you.
I was hoping for the 50 million also in addition that you promised 1:5, but I'm sure we'll find a way to interest you into that.
Sure.
Magda, what's your ask? What's on offer for the early adopters?
My ask.
You might need to use the microphone, sorry.
My ask is that we really get the continents to come together and agree on how we are going to prioritize those countries that will go first, because we risk paralysis and competition if that process is not well managed. Very often it keeps us behind in terms of the process. I would like, the other ask is for us to think systemic, think systems. Data fragmented is a byproduct of the way we approach things. One time is community health workers, another time is vaccine. We need to look into our health system as a whole. That's my bigger ask. If we do that, then we will be able to prioritize, invest, and not forget that health can only move forward if we look at governments or a nation as a whole. It is infrastructure, it's roads, it's electricity, and so on. Thank you.
Thank you. Great.
Thank you very much. I mean, for each of the early adopter countries, I would suggest really to go for one integrated digital health dashboard. And this digital health dashboard should be anchored in Ministry of Finance, maybe with a kind of legal mandate and even a parliamentary in democracies oversight. We need also to make sure that they are linked to one regional mechanism. It might be pool procurement, it might be cross-border insurance, it might be, we have several things. And we should have one blended finance facility with private investors. If those selected countries demonstrate that every, I will use with franc, Switzerland is a neutral country, so every franc trust rules predictable and harmonized, a citizen will see benefits, and really we'll see from that health, we move from fragile recurrent cost to a strategic continental investment.
And you see that as a shared accountability between the private sector and the public sector? Okay, thank you. Veronica.
My ask for the early adopter countries is just to streamline their data systems so that data is not just for reporting, but for filling in any actionable gaps, just to improve trust, not only trust for investors in health, but trust for the patients that walk into our facilities.
So moving data to intelligence for action.
Yes.
Brilliant, thank you. And what do you offer?
For us, we will provide them with technical assistance on performance management so that the managers know how to utilize the data once it's credible.
Okay, so you amplify the existing capacities. Brilliant, thank you. Leo.
If either Abu or DG comes to Dure tomorrow, I say we're ready to go. We'll provide the TA catalytic resources to do a rapid assessment, roadmap, co-design, and begin implementation. Our ask will be, and we'll learn it from the AIDS response, we need to be intentional about making digital transformation a priority. It's not even I'm not using the words anymore, political will and commitment. I would say the political courage to make that choice. Second ask would be, how do we better coordinate? Before coming to this meeting, I was reading a paper where last year, we have documented about 1,000 pilots on different apps going on. If we don't do that, if we don't coordinate, the e-health will become the e-chaos. The e-health will be the e-chaos if we don't strengthen coordination. Thank you.
Thank you. Jerry.
Insurance exists as a resilience layer and to support communities around that may be affected by catastrophic health expenditure. So for me, it will only be two asks. One, we've spoken extensively about Rwanda and the community model that is working. So for the early adopters, I think it'll be great to identify a model that works. I think for all of our countries, we are trying one form of the other of a social health insurance layer. What is working with the Rwanda community model, and how can it be then expanded and scaled? I think that would be critical. The next one, really, the big conversation is often about low insurance penetration. We speak about it often. South Africa is often the example for what penetration should look like. For me, it will be regulatory alignment on three fronts. Minimum standards that will focus on licensing, consumer protection, and of course, dispute resolution. And that then creates some form of opportunity for cross-border portability across the continent.
Wonderful. I'll ask you more later, maybe in private, but about insurance can create jobs, right, in health. So would love to see how we can do that, because that's needed on the continent, but we'll come back. Dayo.
Okay, thanks. So I think early adopting countries, or well, continent-wide, we need regulatory harmonization, we need validation infrastructure, and I'm talking about product development now. We need African data sets. This has been, whether it's for AI or for understanding of biology or immunology, and we need procurement frameworks that will, all of this together produces the market you need to drive innovation and that is required to solve, address problems in Africa. And from where I sit, all of these four domains are missing at scale. Okay, so in terms of we help to bring gene experts to market. We help bring true nuts to market. So we have a track record. And I think for us, we are that layer that is between innovation and deployment. And we are happy to be considered a trusted technical partner in the sort of everything diagnostics, from incentivizing the late phase development to deployment and access, and to even strengthening country systems today. Again, all driven by country priorities, not what we think is needed or should be done.
I would love to see African unicorn in diagnostics. Maybe I can hold you accountable for that, even if you have not promised that. But thank you so very much. This has been really interesting to see the diversity of solutions that need to come together, and the need for us to take a systems approach to make this work. I do believe that there will be a number of countries which will need this collective insight and partnership. So I'm hoping that when you convene the countries together, maybe this is a group that can come back and provide that support. So join me in thanking the panel. This has been an amazing panel. And I've done this only once before in my life, moderating several conversations. I'm going to ask all of you to stand up and thank everybody by saying, you guys have been so amazing staying through this this late in the evening. So really appreciate it. This is one of the best audiences we have had, which is so engaged. Thank you very much. Anne-Marie, back to you. Thank you.
Fantastic. Thank you so much, Pradeep. I think that I have some serious competition. I need to hold on tight to my job. Pradeep, thank you very much to a wonderful lineup of experts as well. So let's now proceed to our final thematic block of the day, which is about changing the narrative, because as we know, if we don't change how we talk about health, we won't change how we fund it. And so to guide us into this new narrative, please join me in welcoming back to the stage the UN Assistant Secretary General and Director of the UNDP Regional Bureau for Africa, Mrs. Ahuna Eziakonwa Onochie.
think the bravest person in the room is our master moderator here. I don't know how you do it, but we must give it to her. I just look at the time, it's 7:15. And I said to myself, I really have to leverage this last session. And my brother, Michel Sidibe, had a topic on trust. So I must say here, I trust all of you to stay awake for the rest of this session. I have the task of taking you through what is it's the topic that's been on the whole day, why health must be treated as capital investment. I don't think we're still answering this question. So I'm gonna focus now because the case has been made. I'm going to focus on the how. I think the discussion we've had since this morning is really very important on how we understand health in Africa. And for too long, we know that health has been treated as a cost center, as a social obligation, as a line item in national budgets. But the evidence is now actually quite clear, and that's why we're changing this narrative. The countries that invest in health unlock productivity, they accelerate human development, and above all, they sustain long-term economic growth, but also they are likely to achieve prosperity. As it is well known here, health is one of those critical determinants of human development, yet we heard that only about 5% of GDP is spent on this all-important sector, and out-of-pocket expenditures account for about 35% of total health spending, which is exposing millions to hardship, untold hardship. At the same time that financing gap is widening, we're seeing external aid either plateauing or just disappearing. Fiscal space is shrinking, and demographic pressures are also increasing. We know that this is a continent that will host a quarter of the world's population in just a few years. So even if countries make it to that 50% target, it's probably already outpaced by population growth in several of our countries. Hence the case for making health investable. So how do we do it? I'm gonna just lay out about 6 or 7 pathways that I've picked up just by sitting and listening to all the conversations today. The one thing that kept getting repeated in the discussion, you heard this word a lot, de-risk, de-risk, de-risk. And this is because capital does not like risk. It runs from it. And if we're talking about investment, if we're talking about capital, we have to do something about risk. So I think there are multiple faces of risk in Africa. There is the risk that exists, the currency risk, political risk, all kinds of risks that are there, conflict risk. But there is also the perception of risk. Africa is a victim of negative narratives that bloat risk perception even when it's not there. And this is a big danger for capital flow into the continent that has to be tackled with narrative change. The real risks have to be de-risked, and there have been many examples here of how that could be done, including applying development catalytic funding to do some of that de-risking. At its core itself, health is about managing risk, individual and systemic. But yet across this continent, health financing systems remain fragmented, as we've heard. Insurance coverage is actually quite low where it exists at all. And it's often unaffordable or limited in scope because insurance is one of the ways you manage risk. In countries with high informality, where over 70% of the workforce operates outside formal systems, traditional contributory insurance models alone cannot work. We need hybrid systems. Systems that combine that contributory scheme with non-contributory tax-funded mechanisms, where governments play a central role in subsidizing coverage for the most vulnerable. But this is not just a health issue, it's actually a macroeconomic one. The ability of governments to finance health depends largely and directly on fiscal space, on debt sustainability, and on the cost of borrowing, which is all been addressed here today. Countries facing high debt servicing burdens, some exceeding 20 to 30% of revenues, have limited capacity to expand health coverage and invest in it. And this is why at UNDP, we are committed to helping African countries secure more accurate and often better improved credit assessments. We're working on this with some of our partners, ECA, as well as AFDB, and this can significantly reduce the cost of borrowing. So there is something we can do about this cost of borrowing, and we are starting to do that, and we're starting to see impact. This has direct implications for health investment. Reduced debt servicing costs will free up public resources that can be redirected towards other investments, including health. The second is creating health as an asset class for investment. We also heard this in an earlier session. If we want to mobilize capital at scale, health must become an investable asset class. Today, health financing in Africa remains heavily dependent on public budgets and donor funding. Yet the scale of needs requires unlocking private and institutional capital. And this means really structuring health investments in ways that generate predictable returns, whether through blended finance, outcome-based financing, or pooled investment platforms, as we heard from several people. It also means de-risking the sector, as I said earlier. We are increasingly working at this interface as UNDP, helping countries design investment cases, structure financing instruments, and connect public priorities with private capital. The third is driving innovation through digital transformation and youth entrepreneurship. This is really my favorite topic. Africa has a unique advantage here. It is the youngest population. It is a land of entrepreneurs. We have many talented young people who are hungry, not in their stomachs, in their heads, in their brains. They want to deliver solutions for wicked hard development challenges. And they are doing so with their tech savviness. You know, there is data that 1 in 5 working age Africans will have startups in a few years. About 3/4 of youths in this continent plan to start one business within 5 years, compared to their peers in Europe or elsewhere, where it's less than 1. So across the continent, health tech startups, for instance, are expanding access through telemedicine, through mobile diagnostics. Somebody talked about the all-important issue of diagnostics. This can be helped by investing in the space of youth entrepreneurs. But we also have AI-enabled solutions. Platforms using simple SMS-based systems are reaching millions who were previously excluded. Think Zipline in Rwanda, for instance. But I want to give you the story of a young woman I met and got inspired by. Her name is Dr. Fumi Adewara. She is a beneficiary of UNDP's flagship initiative called Timbuktu, the largest initiative to support the innovation ecosystem in Africa. Our moonshot is to raise $1 billion to support 10,000 startups and scale 1,000 of them, create 10 million jobs, and impact 100 million livelihoods. Talk about scale. Development assistance must walk away from drip, drip, drip type of assistance. We are now talking scale in a big way. So Adewara, as a young Nigerian, had to face multiple surgeries in crowded facilities in her country. She survived. She moved to the UK And she spent a few years in the National Health Service there. In 2017, she decided to return to Nigeria, and she created what she calls Mobi Health. We picked her up in Timbuktu. She went through our acceleration program. She received a grant of $25,000, small grant, but that grant enabled her to start a partnership with Airtel, which gave her access to 60 million customers of Airtel. Further, she was able to access $1.5 million from Afrexim Bank for project preparation. Here, people talked about the importance of bankable projects for investment. That $1.5 million is expected to help her unlock $65 million in further investment. Mobi Health today has in operation 20 solar-powered telemedicine operations across the country. She is dreaming big. She's not going to stop there. With 65 million on the way, she will expand beyond Nigeria. So you create jobs, you solve health problems, you tackle the issue of the demographics because a lot of young people are involved. And our previous moderator talked about the possibility of seeing a unicorn on diagnostics. This can happen with our young people if we invest in them in a big way. But I wanted to mention something else, which I haven't heard much of today, which is the issue of mental health. I think this continent is not yet focused on mental health, but it's coming. We hear WHO often pushing this agenda, but it doesn't feature that much in the investment area. But mental health is going to be with us very soon. The younger generation, this will be their everyday issue because social media is on there. You will have young people whose health conditions are not visible to everybody because it's in the head. Mental health is so debilitating because it's harder to cure. It's harder to address, it's harder to diagnose, especially on the continent of Africa. So as we talk about investments, I want to say that we pay attention to mental health. Africa can learn from others by investing not just in curatives, but is in prevention, as we heard from the keynote speaker today. What would it look like if most of the industrialization or manufacturing that we've been talking about focused on products that could prevent diseases from getting to a point where they become a burden on systems? Let's think about that. What would that look like to actually invest in prevention? Because we are not going to be able to pay for the cost of the disease burden, no matter how much financing you mobilize. Because of our population dynamics is going to be almost impossible. So investing in prevention, in good diagnostics that stop the diseases before they become a huge burden is Africa's go-to strategy. And this is where I believe we can leapfrog. I want to talk about linking health investment to structural transformation. Ultimately, health investment cannot be isolated from broader economy. Investment follows transformation. If economics remain undiversified, if economies remain undiversified, if value chains remain weak, if productivity remains low, health systems will struggle to attract sustained investment. So health must be embedded within a broader agenda of structural transformation, industrialization, value addition, and economic diversification. For example, when we've been talking about local manufacturing of medical products from pharmaceuticals to diagnostics, This can reduce import dependence, yes. It can help create jobs, yes, and it can also strengthen resilience. And it can tackle informality. The more we can bring more people into the formal economy, the more taxes and tax revenue you can receive, and the more people themselves can pay for their own health services. Africa currently imports between 70 to 90% of its medical products. This exposes it to global supply disruptions, and this has to be tackled with urgency. I want to finally speak about something else that's close to my heart. This is looking at investment in fragile contexts. In least developed countries and among the most vulnerable populations, we must think about including those who have been dislocated as a result of conflict or other destabilization issues. We have 45 million forcibly displaced people on the continent of Africa, the largest region hosting displacement. 45 million people is a few countries in the Africa context. We cannot leave them out as a parallel issue to be tackled from a crisis lens. These displaced people, refugees and internally displaced, must be part of the plan, part of the budget, because it has implications both in the short and long term. These populations can be taxpayers. They're increasingly being integrated into economies of countries. We have good examples in Uganda, in Ethiopia. I served in both countries, and I saw the way doors opened to refugees, and they're being integrated into the economies. This makes them not only human with their dignity, but also it makes them allies in economic development. So I think it's important that we factor in, and I speak to the government members in the room, all planning, all budgeting must take into account those populations. So let me conclude, Excellencies, dear friends, by saying that that new narrative for Africa on health has been born. Africa today stands at a crossroads. We can continue to treat health as a cost-reactive, fragmented, and underfunded issue, or we can reposition health as one of the most powerful drivers of economic transformation, an investable sector, a generator of jobs, a foundation for human development and human dignity, a pillar of resilience and sovereignty, a pillar of stability. Without stability and peace, it's very difficult to have development. At UNDP, we're committed to supporting this transition through financing frameworks, through digital innovation, through partnerships, through integrated development solutions, and through advocating quite strongly and intentionally for investment in our young innovators. Because the future of Africa's economies will not be built without a healthy population. And the future of health will not be secured without investment. Health is not a cost, ladies and gentlemen. It is capital. It is growth. It is among Africa's next frontier. Thank you.
Thank you so much, Director, for that stirring reminder that our narrative is our most powerful currency for change. Let's now proceed to our panel discussion, and I'm calling our moderator, Mr. Omar Ben Yedder, Group Publisher of African Business and one of the heads of IC Publications. Welcome, Omar.
Thank you, Anne-Marie, and thank you for the wonderful discussions. My computer that's been on all day says it still has 40% battery life, which means that we've still got about 8 or 9 hours of work ahead of us. if we may. I only switch off once my battery dies. No, so my name's Omar Benyeda. I'm actually an accountant by training, but I work in media. So here it's about narrative changes and mindset shifts to make sure that, as Huna said, we start looking at health as an investment as opposed to a cost, as rather than it being a burden, that it's something that we need to focus all our attention on. So I'd like to call upon, I'm not sure if he's here, but Mr. Mohammed Al-Hajira, who's the chairperson of the Public Finance Control and Governance Committee of the House of Representatives, Kingdom of Morocco. If you're here, please join us. Ms. Sarah Maka Ugabe, who's the Executive Director for Africa, the One Campaign. Ms. Belinda Ngongo, the founder of the Pan-African Women in Health. Dr. Fungisai Nota, CEO of Nevada Travel, and Mr. Peter Holland, Chief Executive Officer of the International Agency for the Prevention of Blindness. If you can join me on stage, please. Thank you. A round of applause, please. We're going to aim to finish at around in about 30 minutes or so. And I think online we've got the person who's supposed to be moderating this panel, Mr. Kimani Njogu, who will, I don't know if he's online or not, but if he is, we'll get him to make a few interventions as well. Excellent. Fantastic. Is Mohammed Hajira here? No. Okay, very good. So Richard is here from Gavi. But are you joining us?
I think I joined a previous panel.
Okay. No
so, but I'll be happy to contribute from distance. So I just wanted to, not to repeat the same.
Okay, no problem.
Thank you.
And I was told that you weren't here. Okay, fantastic. I mean, one question I was going to ask Mr. Mohammed, who's not here, is because we heard the minister say actually that in Morocco they managed to convince the policymakers to increase budgets in healthcare. So. And he's not here. And really the question was, how do we convince people to focus more on health and to shift their mindsets? Is it a lack of data? Is it why is health not top of the agenda? Maybe I'll start with you, Sarah. And you look as if you've seen a doctor recently. So we'll give you the...
Sure, my experience from being in the hospital. As the last panel or the second to last panel, I think we can make this pithy, and that's the point. I think twofold. Omar, your question was people, and I think we can segment people into our citizens, because I like to bring our citizens into the room. We've spoken to ministers of health and finance all day, and our people need to be in this room with us. So for them, there is a narrative question we should ask. But for our ministers of finance and the ministers of health and the cabinet, I think we have had a really rich conversation all day, but we have to bring in the time horizon and timelines. The Minister of Finance has a crunch for this budget, and he's trying to find as much resourcing as possible to make sure that every other ministry has resourcing. And health has a perception that it's a long-term gestation period before the money actually hits the books. So for them, when you're looking at a 4-year horizon, a 5-year horizon, you're looking at things that can generate revenue immediately. I dare say health can be one of that, but ordinarily we haven't seen health as a short-term revenue generator. That's why there's a hesitation for the ministers of finance and health to become an investable asset class because of the long-term gestation. Now, for the people, I think we're talking about the narrative of healthcare. Healthcare, the narrative is a bridge between the incentives that the Minister of Finance has to bring money and the people's experience. We can't change a narrative until we find solid examples of people experiencing health differently. And if you ask around the continent how people experience health, I think you'll get a mixed response. So while we're building a narrative, we can't gloss over what our people are experiencing, and we can curate the experience to a certain extent, but that's work that we have to do.
And tell me, in terms of what you're doing at One, so obviously we're seeing that overseas development assistance has been reduced or is falling dramatically. So what is it that you're focusing on, and how are you making sure that resources are still going towards development and, in this case, health?
I think three things. First, we've seen that there has been a 15-year drop in overseas development assistance on healthcare. So it didn't start today. It was catalyzed after the USAID pulled out resourcing, but there's been a decline. I think COVID numbers made the picture less dire, but today I think we can all sit together and say there has been a decline. So that incident has provided a moment of a different thinking from African leaders. So that's the first thing. The second thing is we're in a context where post-COVID, many African fiscal spaces have suffered, right? So 30 countries today spend more to service their debt than they do to invest in health or education. So you go to a governor, a president or a cabinet and say, hey, you need more money for healthcare. The question is, where is the money coming from? If I, as a country, am spending 75% of my revenue just to service my debt because of that cost of capital that Ahuna mentioned earlier, where else do they get the resourcing from? So what One is doing is, how do we bring more innovative tools to our cabinet, to our ministries, to our presidencies to say, can we think creatively about where else money can come from to be supplied into the health sector, including things we've heard today like diaspora remittances. How do we use diaspora remittances that eclipses FDI? It eclipses ODA. It eclipses some budgets for domestic resource mobilizations in some countries. How do we channel remittances from a diffused one-to-one to still catering for the people they intend to send the money to, but it's paying for things like insurance, because that is a force multiplier for better health outcomes. How do we work on health for debt swaps? Take these resources that we're owing money on, channel some of that through partnership to go towards health. So there's some innovative tools that we're bringing to the governments so that they can think about this differently. And the last thing is, how do we generate more trust among people? There is a trust deficit across the board. And until we can provide some seeds of hope that we can bridge the trust deficit, we have to bring people along to what their governments are doing, ensure that the conversation between governments and citizens are bringing up more, addressing the issues that citizens have. And we can start this journey of the context we're in, what governments need to do, and the people's role in building this health sector as an investable sector.
Okay, so my last question to you, and I'll stop picking on you, but really it's about mindset shifts. And I know that one thing that you've tried to do or you're doing at One is to make sure that things are more evidence-based.
Correct.
And I think for me, the discussion is all about being about evidence. So I think, and ECA is shifting that, well, I mean, they've always done it, but they're shifting that way to create these dashboards that are open and available to everyone. But in terms of advocacy as well, so one thing is evidence-based, but in terms of advocacy, what are you guys doing differently at One to make sure, again, that resources are going to the right places? So I want to see what mindset shift we need to do and how we can communicate as a community better to make sure that we convince the people that health is investable.
To shift mindsets, I think we go back to the experience. And one of the things we know is on the continent, there is a disproportionate amount of negative news about the continent. So concretely, what we're doing is, how do we tell more stories of what's working data-backed? For example, did you know that Sierra Leone has dropped maternal mortality by 80% since the year 2000. It went from one of the worst places in the world to have a baby as a mom to now improving on its indices. How did Sierra Leone do it over the last 20 odd years? That story needs to be told. When I went to Sierra Leone, it was just at the advent of Mpox, and the government really worked towards ensuring that within 4 weeks, Mpox was stopped. Now imagine if Sierra Leone couldn't manage Mpox, that news would have caught fire. But did anyone know that Sierra Leone actually stopped Mpox in only 4 weeks? No. We didn't tell the story. Things are happening. Evidence is there that there is work being done. And if people don't know about it, both the people within and the people externally, then we never get a chance to shift mindsets. We only continue to reinvest in the negative news coming out of Africa. And even today, we've heard of all the countries doing all the remarkable things, whether it's 90% insurance coverage in Rwanda or 88% in Morocco. How are we telling the stories of the impact of those things with people? And that's our work at One, is we want to tell those stories, both for us as Africans and for the global ecosystem, because that's the only way we get to change mindsets.
Fantastic. So if I can go to Dr. Fungisai Nota. So if I understand correctly, you're in the business of bringing technology to the health ecosystem. So another take home for me today was that there are a lot of leakages ultimately in terms of financing financing health in general. So I think 50% was figure was mentioned. So would you say that healthcare is investable, and would you say that technology will help bridge some of the financing gaps that are needed? And are you able to attract capital to support your business and to support this asset class?
Thank you. Thank you very much. I think you bring up a really, really good point. Can you guys hear me? Okay. You bring up a really good point. I think what we have heard throughout the day is this need to have sustainable financing within healthcare, and it applies to all the different sectors of healthcare. But I think I want to borrow one thing that we don't really look at much. We usually look at countries like the United States and feel like these governments have a lot of money to fund this. Actually, embedded under their systems is a lot of private sector participation that puts a lot of money into public health. Particularly, I work for the last 15 years with a US program called the 340B Drug Discount Program. What they technically did back in 1992, they required all drug manufacturers that sell their medication within the US to give a portion of their profit through a discount back to clearly aligned with the community-based clinics, HIV hospitals, women's clinics, very targeted to that. Last year, those profits accounted to more than $250 billion. That's not coming from Congress. That's not coming from government funding. That's not aid. That's not debt. That's simply a transfer of agreed profit that is being moved to specifically fund public health initiatives in the United States. So within my sector, we are borrowing almost that same concept. For Navala Global, Navala Travel Health, we provide health insurance to international travelers. Right now, we are focusing on the people that are coming for the FIFA World Cup to the United States. We have a network of doctors in all the cities that are hosting the World Cup. So for all the people that are coming, we are saying you can come to our platform, buy a travel health pass, and we will link you with a trusted, vetted local doctor in the cities that are hosting the World Cup. And we are seeing a lot of traction there. But we are taking that model and bringing it to Africa and say, look, last year alone, there were 75 million international travelers that come to the United States, that come to Africa. They come for business, they come for tourism, they come for opportunity. One of the biggest scares that all those international travelers have is, what if I'm in Africa and I get sick? I don't speak the language. I don't even know how to find the doctor. So we are bringing them to our insurance plan, but we're doing something more. We're going to the government and say, look, you already have all these people coming in. Why don't you add a community health levy on the insurance plan? We'll provide the insurance, but the government then mandates a community health levy on top of each plan. If we do that, like if they had done that last year, that could have generated over $1 billion in additional financing that could be earmarked for healthcare, for digital health, for all these issues. And we are seeing a lot of investors that are looking at us saying, if you can do that, that's investable. You are providing insurance, and a portion of that is going to provide care for people that are living at the intersection of poverty and some of the negative health determinants. So there is opportunity for investment, but there's also opportunity to leverage our private sector work with government funding that is sustainable.
And are governments receptive to this sort of public-private partnership?
Yeah, so we just started. Last week, I did meet with the president of Ghana. He launched a very powerful initiative to try to provide free primary health care across Ghana. But the question is, how sustainable is the financing for that model? So here is, he's really interested in working with us. Ghana, for example, last year, they had close to 2.5 million international visitors that come in. A very conservative community health pass for each of those travelers could generate more than $30 million for Ghana alone. And that could fund a big part of the primary care initiative that the president is instituting. So we are continuing meetings next week, but we are seeing some buy-in for that. And we're looking for other countries that want to do the same to partner up with us or with other providers in the private sector to be able to do that.
So what I'm hearing from you, from the two of you so far, is that current circumstances mean that we need to be more innovative in terms of how we look at healthcare, and the penny is dropping in terms of both government and also what they need to do to work with the private sector to deliver on this social good, obviously. So if we can go to Madam Belinda, so in terms of what you're doing and the advocacy on the advocacy side, would you say that people are listening to you more today than they were 3 years ago in terms of your issues? No. Or would you say healthcare is still further down the food chain?
No, thanks very much. And I actually have two hats, because actually a lot of people know me for working in the private sector, but my other hat is really looking at making sure the women are represented. And what I was doing today was I started counting how many women were actually coming here and talking on the panel. I think the first session, I think we only had 3 out of 10 presenters that were women. And I think there was a session that was moderated where they were only male. It was all male panels. And then when you think about it, you look at the healthcare workforce in Africa or even around the world, more than 70% are women. So women are actually the bedrock of our health system. So we need to make sure they are healthy. We need to make sure they are part of these financial discussions. We need to make sure that, they are equipped. Because when you go to a doctor or to a nurse, most of the time, most of the nurses that I've seen are always women. Caregivers are women. There's also the unpaid care workers are women. So I think a lot has to be done in making sure that the budget that are set up are gender responsive budgets. We're not saying that you need to create a new budget for women, but I think making sure that women issues are incorporated in the budget. For example, reproductive health, has to be part of that. Making sure screening, and I think it goes back to the question around prevention. Strengthening our primary health care system. I think that's going to be very important. If we want, an economies to grow, and I think that can also be linked to when we speak about the youth as well, because I think we're talking about the youth, but I'm looking at the room. I'm saying who's representing the youth here. Is it my generation, the generation after me, the generation before me? So I think we need to do a good job to also involve the youth, because we're designing products for them without having their say. So is the advocacy working? I think there's still a lot of work to be done, especially ensure that, as we are shaping this agenda, women voices are part of it. And especially, I think we have a lot in the Ministry of Health, but I think when you look at the financing piece, I hardly see women that are part of the decision-making processes. So how do we make sure that we get them involved? I think that would be my message.
And do you think if women were involved in the decision-making process, more money would be channeled towards the healthcare?
I think more money will be channeled, yes, but I think also we're going to have healthier populations, because they are the ones that are running the system. It's 70% of them working for the health systems.
Yeah, so despite my accent, I'm actually from Tunisia. And so our first president was President Bourguiba. And there's a couple of things he did, but obviously women's right was top of the agenda. And that what, to some extent, gave us, freed our economy and gave us rapid growth. But something that he did, and obviously the Ethiopians probably did it even more successfully, was rural community health centers. And in Ethiopia, actually, once they started to man these health centers with women, the success rate increased because obviously women were more comfortable to speak about their problems to other women. And obviously they're the ones who look after babies and raise families. So that's how they managed to, on the Tedros actually, that's how they managed to increase health outcomes in that country considerably.
And perhaps, when they talk about community healthcare workers, I think a lot of people, we're talking about institutionalizing community healthcare workers on the continent. Most community healthcare workers are women again. So again, you cannot ignore women when you're talking about health financing.
So Peter, you're the CEO, I believe, of the International Agency for the Prevention of Blindness. So maybe your remarks or your feedback on what you've heard today in terms of the discussions that we've had, especially when you bring it into a global context and the direction of travel of these discussions.
Can you hear me? Is that...
But yeah, otherwise feel free to join us in the middle here, get closer to us.
Yes, this one's working. That one wasn't. No, thank you. Well, thank you very much. And I mean, it's been fascinating to be part of, to listen and be part of the conversation today and hear the discussion. And particularly, I guess, coming from an eye health perspective, in some respects, many of the issues that you're talking about in terms of getting health on the agenda and changing the narrative, I feel are almost magnified for us within eye health. In many respects, eye health is almost a niche issue within healthcare, and changing the narrative really has been absolutely critical for us in terms of just getting onto the agenda at all. So we've made a very deliberate effort to reframe eye health and eye care in terms of it not just being a healthcare issue, but being an economic, social and development issue as well. And really drawing on the evidence that shows the impact that eye health has on people's lives, on people's ability to work, children's ability to learn and go to school, and just generally people's ability to participate in society generally. And Ambassador Maguire also pointed out the return on investment in terms of investing in eye care, that for every dollar invested in eye care, there's a $28 return on that investment. And that's particularly driven in terms of economic productivity. So framing eye care in those terms has been really critical for us, because just talking about eye care as a healthcare issue, one of the challenges we have is there are always other healthcare issues that are more important. So the debate around the investment is really fundamental to us, and I think that has begun to bear fruit. We increasingly see ourselves getting on the agenda globally, and interestingly, in many respects, we've got more traction at the United Nations and in discussions around development at the United Nations than we have in discussions at the World Health Organization about health policy. And I think that is because of that framing of that issue. And as Ambassador Maguire said, there'll be the first ever global summit on eye health held later this year, hosted by Antigua and Barbuda alongside the Commonwealth Heads of Government meeting. And I think 5 years ago, we could never have dreamed of bringing, and that will bring heads of government together to talk about it. And we could never have dreamed of that without that framing. I think the other point I want to just touch on was the question you raised right at the beginning around getting political support, and what you were making around actually the connection between people's experience and decision makers. One of the first things I saw, I traveled to Hyderabad when I first started at IAPB, and there'd been a state election there for Telangana, which is a state of 30 million people. And the government had campaigned on delivering primary eye care services and glasses to the population and had won an election on the basis of that. And I think one of the things that struck me was that actually we can have confidence, and I think this is true across the health agenda in terms of turning health into a political issue. But unless we can make those cases and persuade essentially decision makers that it is in their political interest, it's going to be difficult. We won't be successful.
So when you said that you reframed the narrative and you started talking about it as a socioeconomic and development issue, did you have to get some statistics to make your case? I mean, you didn't just overnight decide, okay, look, we need to focus on this. So how did you make it happen? What statistics did you bring to the table?
Yeah, the evidence was crucial, and again, credibility and trust in that evidence base was really critical. So we were fortunate that the Lancet published a Global Health Commission on eye health in 2021, which was really the first time that evidence was drawn out, which showed the impact on productivity, on children's ability to learn, and across a whole range of the Sustainable Development Goals. And we backed that up last year. We published an investment case on eye health, which really drew that out and put numbers behind those figures, and that was where we came out with the evidence that essentially it's $1 investment leads to $28 of return.
Fantastic. So we've got Kimani here online. So Kimani, maybe you want to comment. You're supposed to be moderating this session, so maybe you want to add anything or comment on what's been said, or even ask a question if you'd like.
Well, thanks, Omar. I mean, first of all, thank you so much for stepping in for me, reaching you from Nairobi. I think today has been an amazing day, and it's quite clear to me that what we are being asked to do is to shift the narrative on health by doing a number of things. One, it's to make data relatable, to make health financing relatable to people's lives, turning information that is scientific into stories that then target not just the cognitive domain, but also the affective domain. I think the challenge we have had in the past is really staying too much on cognition and less on the affective of our lives. Now, it's almost a call to a paradigm shift, a cultural shift, a cultural direction that puts people at the center of our work. And that development becomes people-centered development. The other thing that really comes to mind listening to the various presentations is the importance of modeling behavior, modeling practices, amplifying, the early adopters, and beating drums on the success stories of our people. And here I really want to agree with Sarah that we need to shift stories from the negative stories to the positive stories much more. We want to amplify the stories from our communities, our societies, that can give hope, that can inspire our young people as they seek a better future. Now, for narrative shift to be successful, and I'm really talking about this because of the work I've done in the past around HIV/AIDS and so forth, is that it must be multimedia. We must have theoretically driven multimedia approaches to narrative shifts, and that the narrative by itself is not enough. I mean, you must absolutely also invest in infrastructure. You must invest in the facilities that our people go to, so that even as we convince our people to accept the new narrative, they must find a supportive environment for them. And that is, I think that has been mentioned severally. Omar, there is something about trust, and trust has been mentioned from the beginning to, in fact, this panel. You cannot build trust with anything else other than through stories. You must invest in stories that are driven by data, stories that are driven by facts, and connect communities with policymakers so that they can trust, their leaders as they make those decisions. So building trust, building solidarities, building all this through storytelling that is truthful, that is embedded in the lives of the people is really key. And I think that finally, for me, it's really a call not to look at health in silos, but really to look at health in a holistic manner. And I thought that we had agreed a long time ago that health needs to be all government, it needs to be everybody, it needs to be government, private sector, individuals, households, and so forth and so on. And when people talk about the emerging middle class in Africa, we must remember always that this middle class is extremely fragile. It is just one disease away from poverty. And therefore, to secure the middle class, we must invest in it. We must invest in health. We must look at health programmatically as all government work. I can say that in Africa, we have the institutions, we have the people, the youth, we have the creativity, we have creative industries, we have the musicians, we have amazing people who are able to read the environment and recreate that environment in a hopeful way, and we're just ready to start moving forward. And therefore, the investment is ready. Now the question is, how are we going to activate it? How are we going to activate the young people? How are we going to activate the creative industries? How are we going to activate the cross-border solidarities that our people have been making, even without CFTA? So Omar, I think that's all I would like to say, and really to thank you very much for stepping in. This, for me, I got stuck with the connections. Thank you.
Thank you so much for your enthusiasm. And maybe as we close this panel, Belinda, I'd like to come to you again. So with COVID, I mean, health became top of the agenda again. We realized how that, health is wealth, and if you don't have health, then everything comes to a standstill. But what would you say the coverage is like in terms of our own media and within public discourse? In terms of, is healthcare there, or there's not enough quality, trusted, informed discourse around the issue of health?
Yeah, I think it depends on where you are, depend on your level of education. I think there's a need to increase awareness amongst population, because I think when you talk about vaccines, for example, I think there's still a lot of people that they don't trust vaccines, So I think on the continent, I think we need to do a better job to educate people on diseases, on medications, on healthcare in general, and I think empowering frontline health workers could be a way for them to also then pass on the message to people in the communities. And I think working as well very close with the community leaders to ensure that, there is a cohesive message, but also a positive message about the importance of health. I think there's still a lot of mistrust in some ways, I think. And especially I think with the rise of social media, people spend a lot of time on Facebook and on especially at Facebook. I don't have a Facebook account, but I feel like Facebook has a lot of weird things.
TikTok
and TikTok, yeah, there we go. I don't also have TikTok. So I think TikTok, you have a lot of misinformation there. So how do we tackle that? And I know groups like UNICEF have, for example, a venture fund where they fund some femtech or other entrepreneurs to really, for example, look at disinformation for sexual and reproductive health in certain countries. So I think that those are some of the ways to tackle some of these issues. Yeah.
Fantastic. Anyone's got anything else to add?
Just looking at the room here. Looking at the room, I think as we shape a narrative, we need the traditional media and the social media. So I'm not sure, Omar, I know you represent media, but in this room of policymakers, it'll be important to have journalists who understand the nuance and the high level of what we're talking about. So as part of the work we are doing at One is to train journalists around healthcare and to train them around the stories in healthcare so they can cover it as kind of the fourth republic. Social media obviously is a lot more viral than traditional media. So those culture shapers within our communities also need to be part of this conversation. So it can't be a conversation held in the hollow halls of policymakers. It has to be a conversation that's amplified so that those of us, whether there's Nollywood or it's musicians and Afrobeat stars, who are shaping culture can also infuse some of this language and it's accessible to them. So we can't just talk about, less accessible terms like infrastructure and, medical terms. We have to break it down so it's simple for those who are going to take this message and go with and fly with it.
And health, I think, resonates with everyone.
Correct.
On that note, I've got one announcement to make, which is that this year's declaration was shared. And if anyone has any comments, I believe there's an email address there that you can email. It should have been shared on all the desks. Otherwise, a warm round of applause to my panelists before I call upon Abu Bakri to take the next session.
Excellencies, distinguished guests, the next session is easy. It's a closing. I don't have panelists. I don't have a keynote. But I think after a day this rich in ideas, commitments, and ambition, I'm very conscious that I stand between you and what may now be the most engaged, anticipated item of our program, your dinner. So let me be disciplined. I think as we bring this high-level forum to a close, allow me to first express my sincere appreciation to the Kingdom of Morocco for hosting us and for facilitating this event. Also to all the ministers, partners, excellencies, and experts who have contributed to the quality and the seriousness of today's exchanges. What we have achieved today is important, but what matters most is what happens after Tangier. This forum was never intended to be another high-level conversation ending in broad agreement and limited follow-through. It was designed as a platform to move from a political endorsement to practical action, from fragmented efforts to structured pathways, and from discussion about health financing to the hard work of reform, investment, and implementation. That logic has guided the program from the opening session through the fiscal strategy, innovative instruments, country and CMS matching, digital governance, and broader shift in narrative from health and expenditures to health as investment. Today, a number of messages came through with clarity. The fiscal reality is hard, but it's not an excuse for space. The question is no longer whether Africa can afford to invest in health. The question is whether Africa can afford not to. The sustainable health financing will not come from one source, one institution, or one instrument. It requires, and I think we have listened to the different speakers, a new architecture, a stronger domestic fiscal foundation, better spending efficiency, innovative financing tools, credible governance systems, and partnerships that are aligned behind country priorities. Today's discussions have reinforced that these elements must move together if reform is to be serious and scalable. The political commitment remains decisive. Technical solutions exist, financial tools exist, institutional partners are present, but progress ultimately depends on whether countries are ready to align leadership, institutions, and sequencing around credible reform pathways. This is why today's focus on early adopters, country entry points, and concrete deliverables has been so important. Excellencies, dear colleagues, let me now turn to what comes next. In the next phase, ECA will also work with partners to translate today's expression of support into more structured offer for clearly supporting early adopter countries. This includes support on tools, support on data, digital accountability, systems, manufacturing, insurance, communications, and broader implementation accompaniment. The objective will be to ensure that countries willing to move are met with not fragmented support, but with a more coherent package aligned to their chosen reform pathways. The first next step is that we will consolidate the outcomes of the forum into a structured package. This will include the main reform track identified, the country signal expressed, the priority instruments discussed, the partner roles that have emerged, and the immediate follow-up actions required. The purpose is simple. We want to ensure that today's momentum is translated into an operational roadmap rather than left as a record of good intentions. We will move forward with financing commitment registers as a living mechanism of accountability and follow-through. It should not become a catalog of general pledges. It must remain focused on concrete, time-bound, and assignable actions, whether these are technical missions, country scoping exercise, instrument design work, political convenings, or financing preparation steps. The value of this initiative will depend not on how many countries and how many commitments are announced, but how many are implemented. The program has been clear from the outset that this forum is about the datable and assignable commitments, and that principle will guide our follow-up. ECA will work with interested partners and countries to support the emergence of an early adopter coalition. The objective is not to create a large and symbolic group, is to support a credible first set of countries willing to move from political interest to reform action. For those countries, our task in the coming period will be to help clarify the entry point, the sequencing, and the partnerships needs, and the practical deliverables that can be advanced in short term. We will activate the technical follow-up architecture required to support the implementation. Today has shown that countries need support not only in advocacy, they need support in fiscal analysis, in instrument structuring, in governance design, in data systems, and transaction preparation. We therefore intend to strengthen the coordination between ECA and our institutional partners so that countries that wish to move are met with coherent support rather than fragmented efforts. The forum has highlighted that digital governance and accountability systems are not peripheral issues. They are part of the confidence infrastructure that makes finance credible. The live discussion on governance, data, and digital tools reinforce that transparency, traceability, and institutional trust are central to mobilizing sustainable investment and scaling reforms. This means that our follow-up must integrate financing and governance together, rather than treating them as separate agendas. We will carry forward the political and public narrative launched today through Invest in Health Africa initiative. This narrative shift is not cosmetic, it is really strategic. If health continues to be framed as a recurrent social expenditure, Reform Coalition will remain weak and short-lived. It is understood instead as an investment in human capital, in productivity, resilience, and sovereignty. It becomes easier to defend in budget debates, easier to sustain politically, and easier to integrate into national development strategies. The campaign and the charter that we are launching today must therefore become instrument for maintaining momentum beyond this room. Excellencies, distinguished colleagues, ladies and gentlemen, let me be very clear. The success of this forum will not be measured by the quality of our speeches today, but the discipline of our actions tomorrow. Success will mean that countries which signal readiness are supported rapidly and credibly. Success will mean that the first country instrument pathways become real pipelines. Success will mean that partners aligned around delivery rather than competing around visibility. And success will mean that ministries of finance and ministries of health work from a shared reform logic. And lastly, success will mean that health financing begins to move from the margins of public debate to the center of macroeconomic and development strategy in Africa. For its part, ECA is committed to playing its role fully. We will convene, we will connect, we will provide technical support where we can. We will help structure partnerships. We will help sustain momentum, and we will keep our focus where it belongs, on country-driven reform, implementation, discipline, and measurable follow-through. Allow me to conclude with this. Today, we have not solved the health financing challenge for Africa, but we have done something meaningful. We have helped build a stronger basis for collective action. We have brought together the political, the technical, the financial, and the institutional actors that must be part of the solution. We have started to define the pathways. We have begun to identify the countries willing to move, and we have made clear that this initiative is not about aspiration alone. It is about execution. So let us therefore leave Tangier with a shared understanding. This forum is not the end of a conversation. It's the beginning of a disciplined implementation process. The real work starts now, and I thank you.
And another big thank you to you, Aboubakry Diaw. I think he deserves a huge round of applause. He's one of the architects behind this landmark event. Thank you very much. The program was very ambitious, but we've done it. And indeed, the work starts now. It continues in the ministries, parliaments, Market Square, everywhere. So before we say goodbye, I just want to invite you all to a reception next door at the Movenpick for dinner. We'll carry on talking. As for me, I really want to thank you all. It has been an absolute pleasure to be with you today. Have a good evening. Bye.
Recording stop.